A very good afternoon to one and all present over here. Today we have gathered here to commemorate late Vaidya Shankar Dajeeshastri Pade's Memorial Lecture 2022, which has been organized by Ayurvidya Prasarak Mandal in collaboration with Mumbai Vaidya Sabha. So now I'd like to call dignitaries to the dais. Firstly, I'd like to call Dr. Rajeshkumar Gupta, sir, who is the president of the function. Sir, please come forward. Now I'd like to call Dr. Amarprakash Dwivedi, sir, who is the guest speaker today, to come forward. Now I'll request Vaidya Dinanath Upadhyay, sir, who is the president of Mumbai Vaidya Sabha, to come forward. And now I'd like to call Rajendra Sharma, sir, Vaidya Rajendra Sharma, sir, who is secretary, Mumbai Vaidya Sabha, on the dais. Now I'd like to call Vaidya Dinanath Upadhyay, sir, President Mumbai Vaidya Sabha, on the dais. Now I'd like to call Vaidya Satpute, sir, who is the principal Ayurved Mahavidyalay, Sion. Now I'd like to call Shri Ranjit Puranik, sir, President Ayurvedic Prasarak Mandal, on the dais. So today we are honored to have Vaidya Rajeshkumar Gupta, sir, who is ex-associate professor, Shalya Shalakya Tantra of Bhaisaheb Sawant Ayurved Mahavidyalay, Sawantwadi College, and our guest speaker, Dr. Amarprakash Dwivedi, sir, who is professor Shalya Tantra and vice principal of School of DY Deemed University, Navi, Mumbai. Now I'll request the dignitaries to come forward for the Prajwalan. To call upon Dr. Anupama Jog ma'am of Sahita department for enchanting Dhanvantari Stavan, and I request everyone to stand up in respect for the Dhanvantari Stavan.
Shankham Chakram Jalaukan Dadhata Amruta Ghatam Charudaurбhih Chaturbhih Sukshma Svachhati Rudyan Shuka Parivilasan Maulimam Bhojanetram Kalam Bhodojvalangam Katitat Vilasascharupitambaradhyam Vande Dhanvantarim Tam Nikhila Gadavanam Praudhadavagnililam.
I also request Dr. Shyam Nabar, sir, of Ayurvedic Mahavidyalay, Sion, to come to the dais. Function, I'd like to call Honorable Dr. Rajendra Sharma, sir, for addressing late Vaidya Shankar Dajeeshastri Pade's legacy. Dr. Rajendra Sharma, sir.
अज्ञानतिमिरन्दस्य ज्ञानांजन शलाक्या चक्षुरुन्मिलितं तस्मै श्रीगुरुवे नमः। सभी गुरुजनों को प्रणाम करते हुए आज हम सब लोग यहाँ एकत्रित हुए हैं श्री स्वर्गीय शंकर दाजी शास्त्री पदे इनकी स्मृति में एक व्याख्यान के अंतर्गत मुंबई वैद्य सभा और आयुर्विद्या प्रसारक मंडल दोनों के सहयोग से हम प्रतिवर्ष की भांति इस वर्ष भी ये व्याख्यान आज आयोजित कर रहे हैं। शंकर दाजी शास्त्री, इनका थोड़ा सा आपको परिचय दे दूं मैं। ये इनके पूर्वज पूना के नज़दीक नारायण गांव के निवासी थे। इनके पिताजी प्रकांड ज्योतिष थे और ये पेशवाओं के यहाँ वेदों के मंत्रों का उच्चारण करते थे, इसलिए उन्हें पदे ऐसी उपाधि दी गई थी। मूलतः ये यहाँ बम्बई में नागपाड़ा मोहल्ले में रहते थे और यहीं शंकर दाजी शास्त्री पदे इनका जन्म हुआ। आज ही के दिन 30 मार्च 1867। संस्कृत, व्याकरण, इन सब का अच्छा इनको ज्ञान था। आयुर्वेद के लिए इन्होंने श्री भानु वैद्य कुलकर्णी जी, इनके यहाँ कर्माभ्यास, योगाभ्यास जो भी किया, अध्ययन किया गुरु शिष्य परंपरा में। और इनका हिंदी, मराठी, संस्कृत सब भाषाओं पर बहुत अच्छा अधिकार था, अच्छे ज्ञाता थे। इसीलिए ये अल्पावस्था में ही लेखन कार्य से, संपादन से जुड़ गए विभिन्न पत्रिकाओं में। और उनकी प्रतिभा को देखते हुए बड़ौदा के जो राजा थे गायकवाड़ जी, इन्होंने अपने यहाँ इनको बुलाकर पत्रिका का जो कार्यभार था सब इनको सौंपा। 2-4 वर्ष उन्होंने वहाँ कार्य किया, फिर वापस चले आए। इन्होंने बड़ौदा का नरेश जो सयाजीराव गायकवाड़ थे उनके नाम से और आयुर्वेद विद्यापीठ की स्थापना भी की। आयुर्वेद के प्रचार प्रसार के लिए हर तरह की कोशिश करते रहे। अल्पायु 17-18 वर्ष की उम्र में उन्होंने एक पत्रिका निकाली, राजवैद्य, और इतनी छोटी उम्र में वो इससे इतने प्रसिद्ध हो गए कि उनकी दूर दूर तक ख्याति हो गई। फिर उन्होंने एक हिंदी पत्र निकाला, वैद्य कौस्तुभ। उससे उन्होंने करीब करीब हिंदुस्तान में सब तरफ, खास करके उत्तर भारत में उनको बहुत प्रसिद्धि मिली, अच्छा कार्य करते रहे और आयुर्वेद के प्रति समर्पित थे। अपने उसी समकालीन वैद्यों के साथ मिलकर मुंबई वैद्य संस्था की स्थापना की। उनमें उस समय के काफ़ी नामी गिरामी वैद्य थे, प्रभुराम वैद्य, दयाशंकर, ये शंकर दाजी शास्त्री पदे, ये सब डॉक्टर कुंटे, इन्होंने मिलकर वैद्य सभा की स्थापना की। और इतने महान लोगों ने इसमें भाग लिया, जो वेणी माधव जी शास्त्री, श्री राम गोपाल जी, बड़े बड़े वैद्यों ने इसमें अपना पूर्ण योगदान दिया। और हम गर्व अपने आप में महसूस करते हैं कि हम उसी संस्था के अंतर्गत कार्य कर रहे हैं, उन्हीं से जुड़े हैं। और आज जहाँ भी हमें मौका मिलता है हम कुछ न कुछ कार्य करते रहते हैं। अभी पिछले 2-3 वर्षों से हम कुछ ज़्यादा नहीं कर पाए ये कोरोना की वजह से, लेकिन फिर भी ऑनलाइन के लिए हम लोगों ने इसके लिए तैयारी शुरू की। और योगा के लिए तो हमने सर्टिफिकेट कोर्स भी शुरू किए मुंबई वैद्य सभा और प्राण योगा सेंटर के साथ में मिलकर। और करीब करीब पहली बार ऐसा हुआ 40 डॉक्टर एक साथ में इस कोर्स को कर पाए। और आगे भी हमने लेवल 1, लेवल 2, लेवल 3 ऐसे उसको कंटिन्यूस चलाते रखा। आज हमारा सौभाग्य है कि हम फिर से एक बार में हम आपस में सामने ऑफलाइन ये मीटिंग शुरू कर रहे हैं। मुंबई वैद्य सभा से जुड़कर और आप इसी तरह इस आयुर्वेद के यज्ञ में अपना योगदान देते रहें, कार्य को बढ़ाते रहें, प्रचार प्रसार में किसी तरह की कमी नहीं रखें, तो मैं समझूंगा ये हमारी सच्ची श्रद्धांजलि है सभी अपने पुराने जितने भी गुरु वैद्य जो हुए उनके लिए। मैं अपने 2 शब्द पूरे करता हूँ। नमस्कार।
Thank you, sir, for your enlightening words. Now I'd like to call upon Shifa Kazi and Anam Siddiqui, students of final year BAMS, to tell us more about our Honorable President and guest speaker of the function.
One and all present over here, I am here to introduce Dr. Amarprakash Dwivedi. Honorable Dr. Amarprakash Dwivedi has completed BAMS, MS Shalya Tantra and PhD from R.A. Podar Government Medical College, Mumbai. He has also completed an instructional course in advanced coloproctology and even an instructional course in laser treatment in proctology from Poland. He is a well-known proctologist and anorectal surgeon practicing for more than 15 years. He is an authentic piles, fissures, fistula and Shar Sutra therapy specialist. He presently holds the post of Vice President and Professor and Head of Surgery Department at Dr. D.Y. Patil Ayurvedic Hospital, Navi, Mumbai. Dr. Dwivedi has been awarded with many national as well as international awards like Aryabhatta Award from the USA, Sushruth Award from UAE, Dhanvantri Award from Rajkot, Gujarat in India, International Excellence Award from Malaysia. He has also received an award from Sri Lanka for expertise and research in Ayurvedic anorectal pile surgery, the renowned Shar Sutra therapy. He has invented the ADR Shar Sutra kit, an advanced Shar Sutra cum application device, and even a modified Agni Karma device. He has published more than 100 research papers in peer-reviewed scientific medical journals and more than 50 articles published in various health magazines and newspapers or public health subject. He has 6 books to his credit on topics like cardiology, urology, nasya karma, obesity, and other parasurgical process in Ayurveda. We are truly honored to have his presence over here and honored to have his lecture on the dais. Thank you.
Good afternoon, everyone. I am here to introduce Vaidya Rajeshkumar Gupta sir. Vaidya Rajeshkumar Gupta sir is an accomplished surgeon who has operated more than 45,000 patients in last 35 years. He completed his graduation from R.A. Podar Medical College and post-graduation in Shalya, Shalakya from Tilak, Maharashtra, Vidyapeeth, Pune in 1986. He has a vast academic experience of more than 30 years. He retired as Associate Professor, Shalya Tantra Department, Bhaisaheb, Sawant Ayurved Mahavidyalay, Sawantwadi, and still continues to work at RGVS Hospital. He functions as an examiner for PhD, UG, and PG in Shalya, Shalakya, and Sharir at prestigious Banaras Hindu University, Shalya Department, and also at MUHS. He has been associated as life member with NIMA, Deccan Surgical Society, Indian Red Cross Society, Sindhudurg, and some other association. He is the founder, president of NAB Sindhudurg. He has received many awards such as Shushrut Ratan 2002 by National Shushrut Association, Ashwini Award at AAI 2004, Konkan Bhushan in 2015, and recently Lifetime Achievement Award by SDDC Bank Sindhudurg in 2020. He participated as operative surgeon in live demonstration workshop at Proctology Update 2005 held at YMT Medical College, Kharghar, Navi, Mumbai.
Moving forward, I'd like to call upon Dr. Rajendra Sharma sir for enlightening us more about today's president, Dr. Rajeshkumar Gupta sir, and our guest speaker, Dr. Amarprakash Dwivedi sir. Thank you. Our principal sir to felicitate them.
Moving forward, I'd like to call Dr. Amarprakash Dwivedi sir for conducting today's lecture on proctology. Please welcome him with a huge round of applause.
Om Dhanvantare Namah, Om Namo Venkateshaya. Good afternoon, respected chairperson Dr. Rajesh Gupta ji, all the dignitaries of the dais, the managing committee members of APAPM, Sion Ayurved Mahavidyalay, all the office bearers of Mumbai Vaidya Sabha, respected teachers and my dear students. My sincere regards to you all. Friends, I really feel fortunate and honored to get this opportunity to deliver my talk on esteemed late Shankar Dajeeshastri Pade oration 2022. My topic for today's presentation is Proctology Simplified, in which I would like to share my insights, highlight about the diagnosis and management of common anorectal problems with an integrated approach and of course in a simplified way, and my effort will be like everybody after my lecture should be practicing proctology, at least the conservative management part, because surgery again is a skill-based technique and you require certain learning curves for surgery. So there are certain limitations for it, but definitely the treatment part, the medicinal treatment, you will be definitely able to diagnose and treat the cases. So let us start. You can see the various anorectal conditions which ranges from the skin diseases, simply from the fungal infection to warts, polyps. These are the minor surgical anorectal conditions which requires sometimes medicines like antifungal cream and treatment, and sometimes minor surgical interventions are required. Thereafter, the list is the common anorectal problems: hemorrhoids, anal fissure, abscess, fistula in ano. So these are the major anorectal cases we see in our day-to practice. And again, pilonidal sinus, malignancy, and rectal prolapse. So these are the list of anorectal conditions which we see in our proctology practice. Few slides are basically for orientation purpose, because you should know about the basic anatomy, pathogenesis of the condition. So here I have tried to simplify the definition of proctology. You know, it involves knowledge of rectum and anal canal. Now here in this image itself, you can see this is a wonderful image. You can see this part, above this is rectum. So rectum is the most distal part of the GI tract, which is around 14 to 60 centimeter, and the anal canal is 4 centimeter and directed downwards and backwards from the rectum to the anal orifice. So these are the two surface markings we should know. And there is one more anatomical consideration about a dentate line. This is very important. Here you can see there is an imaginary line basically which divides the anal canal, above which it is generally insensitive part, that is the applied part of it, and below the dentate line is highly sensitive because of the somatic nerve supply. So you should know knowledge of this dentate line. Further, when we're discussing about the hemorrhoids, there are two more structures you should know about the hemorrhoidal plexus, because the pathogenesis of hemorrhoid lies there. Now these hemorrhoidal plexus are categorized as internal hemorrhoidal plexus, where the internal hemorrhoid originates, and then the external hemorrhoid, which is below the dentate line. Then the blood supply also, one should know that the major blood supply to the rectum and anal canal is from the superior rectal artery adjacent to the middle and inferior rectal arteries. Then we know the location of these arteries. It is, if the patient is placed in a lithotomy position and his anal verge, if you consider as a clock, then it can be divided into like 11 o'clock, 3 o'clock, and 7 o'clock. So these are the positions of rectal vessels, and there we find the primary hemorrhoids. So the location of primary hemorrhoid is 3, 7, and 11. We will directly go to the first major conditions, that is hemorrhoids. In Ayurveda, the terminology given is arsha. Now here I can see, 3 generations of ISM doctors. I can see my seniors who have pursued their graduation maybe before 90, maybe from 1970 to 1990. Then my contemporary doctors, I can see many of my colleagues here, they have pursued their graduation till 2000, I can say, and thereafter the budding doctors. Now, why I am telling this is because before 1998, the definition of hemorrhoids was totally different in modern science. What the definition was, if you remember Dr. Sharma sir, it was dilatation and protrusion of hemorrhoidal veins from the anal canal is hemorrhoid. So that was the definition. But now the definition, as per the advancement in the anatomy and histopathology, now they have changed the definition itself. Now the definition is, it is nothing but a masses or clumps of tissues within the anal canal, which contains blood vessels and surrounding supporting tissue. Together they are called as anal cushion. So it is prolapse of anal cushion. So why I am telling you this? Because the modern surgery definition, pathogenesis, treatment, everything is variable. They get changed time to time. But you can see the flow chart given by Shushruta Samhita. It is one and the same, and that is why it is Shashwat. आयुर्वेद में अर्श का जो संप्राप्ति और definition बताया, that is same, and it is very much resembling to the recent definition of hemorrhoid. What Sushruta says that if an unself-possessed person, जिसको हम जो जितेंद्रिय नहीं है, जो अनात्मवान आदमी है, if the person is indulged persistently into unsalutary lifestyle and food habit, also into the strenuous work like fighting with the opponent and all, then unsalutary diet we have already discussed, and most important, vega dharan, suppression of urge. So all these things together, if practiced for longer time, that person will definitely have vata prakop. There will be vitiation of vata, and this vitiated vata will disturb the agni. So the basic pathology is Agni Dushti and Vata Prakop. Together they will further propagate, and they, affect the surrounding Pradhana Dhamani. See the beauty of Sushruta Samhita. He has not mentioned Sira. उन्होंने क्लियर बताया है प्रधान धमनी अनुप्रपद्या अधोगत्वा गुदमार्गस्य, means they affect the superior rectal vessels or the hemorrhoidal plexus, and then they are lodged into anal canal, and there they disturb the function of sphincters. And thereafter, there is a mass-like growth coming out, Maunsa prarohana janayanti arsha. So this is how the arsha is developed. So the definition given in Sushruta Samhita 1000 year BC and the most advanced definition in modern surgery text is almost same. Further, about the pathogenesis, we all know bleeding per rectum and all, which is because of the, development of hemorrhoid diseases, starting from the dilatation of cavernous bodies of the anal cushion, leading to rupture of the arteriovenous shunts, and thereafter the bleeding takes place. I was talking with seniors here about the prevalence rate. So this is the statistics. You see, around 50% of the population, they develop hemorrhoids some or other time of their lifespan. Then the gender ratio, again here, females are male are more prone to develop hemorrhoids. The ratio is 2:1. And we all humans suffer from this disease because of our erect posture. हम खड़े रह के चलने वाले प्राणी हैं, इसलिए because of the gravity there is always overfilling of the hemorrhoidal plexus, resulting into hemorrhoids. Etiological factor will not go in details. Apart from the first two, the congenital and anatomical, all other causes like sedentary lifestyle, alcohol, suppression of urge, BPH, COPDs, vigorous coughing, weightlifting. In females, again, 3 distinct causes like during pregnancy, at the time of labor, and huge fibroid. All these etiological factors, they increase the intra-abdominal pressure, resulting into overfilling of the hemorrhoidal plexus, and then the hemorrhoid is developed. Now, about the congenital, even in Sushruta Samhita was describing 6 types of arsha based on the predominance of doshas, vataj, pittaj, kafaj, sannipataj, raktaj, and sahaj. So, sahaj is nothing but bija dosha janya arsha, which is congenital hemorrhoids. Further, the classification, again, we can skip this slide. There are 4 stages of piles or hemorrhoids. Like in initial phase, grade 1, there will be spontaneous bleeding, but there won't be any lump or clumps. Grade 2, there will be some mass-like growth will come out while defecation, but it will reduce spontaneously. Grade 3 is something protrusion which requires manual reduction. Means patient will say that he has to push the content coming out of that. And grade 4 is irreducible hemorrhoids. Now, this is something related to your practice, that the basic division of hemorrhoids are external hemorrhoids and internal hemorrhoids. My dear students, please always remember these images here. This is external hemorrhoid. There is a big confusion in the fraternity, the practitioners, that anything coming out which can be touched, that is external hemorrhoid, and which is the hemorrhoid which is inside the anal canal is something internal hemorrhoid. The fact is not like that. It is totally different. In external hemorrhoids, patient usually present with perianal hematoma. So there will be clinical presentation like this. Then the onset will be acute of nature. And then there will be sudden onset, painful lump, swelling, that will be of bluish color because of the collection of blood, and that will be covered with smooth, shining skin, and this will be followed, if not treated, will convert into thrombosis. Then what is internal hemorrhoid is seen here. It is inside, it originates from the above the dentate line. And it will, clinical manifestation will be like painless bleeding and protrusion as per the grades we have discussed, grade 1 to grade 4. You know, in internal hemorrhoid, pain is minimal or no pain. That is how you can differentiate. Now we'll directly go to the management part. We'll first discuss about the modern, the allopathy management, and then we'll discuss the Ayurvedic part as well, and the surgical part also. So management, as the types of hemorrhoids are different, like external and internal, both have different presentation, different sign and symptom. So the line of treatment also is different. You cannot have a tailored made treatment for every hemorrhoid patient. You have to select, you have to diagnose it properly and give the proper treatment. For external hemorrhoid, as we have seen in this, there will be perianal hematoma and severe pain. So the treatment is also according to the sign and symptoms. You can advise analgesics, anti-inflammatory drugs, local anesthetic drugs can be given, sitz bath with potassium permanganate can be advised, and if bleeding persists, you can always give hemostatic drugs and laxatives. So that is the line of treatment for external hemorrhoid. Only thing is, you have to check the patient physically, and if you find it is external hemorrhoid, then you have to give this line of treatment, which is very basic line of treatment. But if the symptom does not subside with the conservative management, then there is a small minor surgical intervention known as incision of the perianal hematoma, and that the clot inside will be removed, taken out, and the wound will be laid open to heal. So that is about the management of एक्सटर्नल हेमरॉइड्स. सो आपको यहाँ पे एक इंसिजन लेना है, लोकल एनेस्थेशिया देके ये जो क्लॉट जमा है वो निकाल देना है, एंड देन यू विल कीप द वुंड टू अलाउ हील बाय इट्स ओन. Coming to the internal hemorrhoids, this is also very important. As we see in clinical manifestation, there will be constipation, there will be pain, minimal pain, and there will be, bleeding per rectum. So the treatment of internal hemorrhoid is divided into 3 different sections. The first section is about the grade 1 and grade 2, where actually there is no requirement of treatment. You should only educate the patient for a proper salutary lifestyle and diet. That is what is required in internal hemorrhoid in the initial phase. Diet and lifestyle modification. Thereafter, if the disease progresses, you may always offer parasurgical procedures, or commonly known as office-going procedures, which are sort of daycare surgeries, daycare interventions that can be offered. And for grade 3 and grade 4 prolapse, thrombosed piles, definitely Shastra karma or surgery is the choice of treatment. Now here, for the practitioner, I have tried to compile the line of treatment for internal hemorrhoids. Like orally, for internal use, you can always give micronized flavonoids. The common brand name available is Deflon, 500 milligram and 1000 milligram. So that Deflon is very much effective in treating internal hemorrhoid, which actually having anti-inflammatory property. At the same time, it inhibits the vascular damage. तो आपने देखा होगा arteriovenous shunt break हो जाता है, so that is taken care with the Deflon. There is another very good combination, dobicelate and proxyrutin. The brand name is Rutin capsules. That is also very good drug, which actually increases the strength of the capillaries. So these are the two drugs you can offer. If bleeding is significant, you can give hemostatic drugs like proxenic, ethamsulate, pause, and those things. Then you have to give laxatives. Again, you have multiple choices like Dufelac, lactulose, sodium picosulfate, isabgol, senna, and all. And you can always give certain local preparations such as hydrocortisone, heparin, Anovate. There are many local preparations available. So that is the line of treatment for internal hemorrhoids. Here I have tried to compile the entire treatment alternative in modern science. You can always categorize into non-surgical options and surgery. For non-surgical options, definitely there are very good effective measures such as sclerotherapy, rubber band ligation, infrared coagulation, laser ablation, and hemorrhoidal artery ligation. These all are the office-going procedures or daycare procedures. And again, if patient is not responding to all these previous treatment, then you can always offer the surgical intervention. The commonest practice surgery is hemorrhoidectomy. Now again, hemorrhoidectomy, there are two different types like open and closed. And then most advanced hemorrhoidectomy is stapler MIPH, that is minimal invasive procedure for hemorrhoids. This we can definitely skip. This slide actually gives the mechanism of action of these office-going procedures. Like sclerotherapy, what it does, it decreases the vascularity and increases the fibrosis, which actually fixes the mucosa to muscle and which prevent the prolapse. That is the mode of action of that drug. We are using esclarol, that is. Then infrared coagulation, इससे क्या होता है? It coagulates the tissue protein and dehydrate the cells, which causes post-burn fibrosis. Hemorrhoidal laser ablation is nowadays very famous and accepted treatment in which the hemorrhoidal artery flow feeding the hemorrhoidal vessels, plexus, is stopped by means of delivering the Doppler guided laser coagulation. And then the rubber band ligation, we all know it is, rubber band is ligated to the internal pile pedicle, which actually strangulates the feeding blood vessels and gradually cuts the external component. Coming to the established surgical techniques for hemorrhoids. Now here, as we have discussed earlier, that the best practice surgery is hemorrhoidectomy, which is very effective, having a rare recurrence rate, but disadvantages are always like patient requires hospitalization, there will be a raw wound, pain, and there is always chance of sphincter damage and anal stenosis, and those complications are bound if surgery is not done properly. And then the advanced surgical procedures. This is Longo Technique or stapled anupexis. This is done with the help of this disposable device. It is very costly. The cost of the instrument itself is around 30,000. And the technique is very simple. With this device, what they do is, they take a circumferential suture in the anal mucosa, which fixes the mucosa. At the same time, they excise the external component by scraping technique sort of thing. So that is what MIPH is, but it is a wonderful treatment, requires 1 day hospitalization, and even there will be no pain, no discomfort to the patient. So those who can afford it, definitely for grade 3 and grade 4, stapled hemorrhoidectomy is the choice of treatment. Finally, coming to the Ayurvedic management part, because as I said, we will be focusing on the integrated approach. We should know about the Ayurvedic management. What Sushruta has given treatment regimen for Arsha. So Sushruta has given 4-fold therapy. चार अलग अलग ट्रीटमेंट दिया है डिपेंडिंग ऑन द स्टेजेस ऑफ हेमोरॉइड्स. अगेन औषधि, क्षारकर्म, अग्निकर्म एंड Shastrakarma. Now here every word is important. Sharakarma means Sharakarma. It is not Shar Sutra. You have to be very clear. Aushadhi Chikitsa is indicated in grade 1 and grade 2. We will discuss the treatment alternative as well. Sharakarma is something, the medicated alkaline paste to be applied on the pile pedicle, useful in grade 2 and early grade 3. Agni karma is giving heat burn, which can be correlated with, laser ablation sort of thing. And then the Shastra karma. Shastra karma described for Arsha Chikitsa is very much similar, or I can say the hemorrhoidectomy technique is very much similar to Shastra karma of Arsha mentioned in Sushrut Samhita. Coming to the conservative Ayurvedic management of Arsha. See, principles never change. So the line of treatment is always fixed. Only option is the formulation. So, in Ayurveda, we cannot have a same line of treatment to every Arsha patient. It won't be effective. You have to customize the treatment based on these Chikitsa Sutra. Like we know that the basic cause is Vata Prakop and Agni Dusti. So you have to consider these things, and while selecting the treatment options, you have to consider the Prakruti and cost of the patient. That is most important, because a person having Mrudu cost, if you give strong laxatives like Abhayadi Modak sort of thing, he will start dysentery, loose motions like that. So you have to customize your treatment and select your own group of drugs and make a formulation. For Deepan and Pachan, you have various options, right from the Am Pachakvati to Hingvastak Churna. Vatanuloman Chikitsa, always, you can give Avipattikar, Triphala. For Malasaran, you can give Haritki, Triphala, Gandharva Haritki, Abhay Arrest, various options you have. Raktasthambhan, again, if bleeding is significant, you can give Nagkeshar Lodra. In practice, you can simply advise a patient to take a banana, cut it from the middle, put some Nagkeshar Churna around 250 milligram or some, and add some loni or butter to it, and ask him to take 3 times a day. That will definitely arrest the bleeding. And again, from Dhootapapeshwar, there is a fantastic drug, Raktastambhak Vati, which is very effective in hemostasis. Then, there are certain topical preparations mentioned in Ayurvedic text. Local application ke liye bhi options hai aapke paas. You can, take a fresh Snuhi latex and add Haridra powder to it, and you can directly apply over the pile pedicle inside. Then, Kasisadi Tail, Kasidadi Malhar, Pippalyadi Tail, Nimbadi Malhar, and again, Arshahita, you must be using it, having very good result, and patients are mostly satisfied with this line of treatment. Sushrut has also given certain dietary regimens along with the internal palliative medicines like grill mixed with घृता and milk. This is, वो पढ़ने में थोड़ा सा English word अच्छा लगता है. It is खीर. आप खीर खाने को दीजिए, मूंग की खिचड़ी खाने को दीजिए. Then, Shatavari Mool Kalka with milk can be offered to the patient, and buttermilk. Buttermilk के ऊपर तो पूरा एक अध्याय लिख दिया उन्होंने, महात्म्य of Takra. So, which has Agni Deepan, Agni Pachan, and Vatalumal. All 3 properties are there in Takra. Then there are certain proprietary formulation like Suran Pindi Vati, Kankayan Vati, Arshahita, all having good results. Next part is, there is a lot of debate on use of Kshara in hemorrhoids. Now, while describing the 4-fold therapy, I have made it very clear, Sushrut has mentioned Shara Karma and not Shara Sutra. Shara Karma mein kya karte hai? You take an Pratisarani. We all know about Shara. It is of 2 types. Paniya Kshar, which is to be taken internally, and Pratisarani Kshar for local application. So here, what is expected is the Pratisarani Kshar. So Mrudu type of Pratisarani Kshar can be prepared as mentioned in the text, and that Kshar is applied right on the mucosa of pile pedicle. And thereafter, after applying and waiting for 100 seconds, you have to wash it with dhanyamla or lime water. This lime water basically neutralizes the alkaline paste, and thereafter you have to put the sneha or yashtimadhu ghrut can be applied over the pile pedicle. So that is what shara karma is, which is mentioned in grade 2 and early grade 3 hemorrhoid management or arsha management. Now, we have seen certain area of India where the Ayurvedic surgeons, they, ligate the pile pedicle with Shara Sutra. So, I will not say that they are doing anything wrong, but in my practice, I do not use this for ligation of internal hemorrhoids. But for external hemorrhoids and thrombosed condition or sentinel tag sort of thing which is seen in fissure, those cases can be definitely, you can have a free ligation. See, in hemorrhoid surgery, what ligation is done, technique is done is transfixation suture. Here it is free ligation. You have to simply ligate as we do in rubber band ligation. So, what I will give a message that you should not use Shara Sutra for ligating the internal hemorrhoid, but you can use it with your expertise in external hemorrhoids. So, the first major anorectal condition, I think I have tried to justify. You know the diagnosis part of hemorrhoid, you know the choice of treatment in modern medicine and surgical alternatives, everything we have discussed. And with the kind permission of august audience, we will take the second condition now, that is most common anorectal problem, that is fissure in ano. In Ayurveda, the terminology for fissure is parikartika. Students. So there is a lot of confusion because there is a similar word parivartika. So in Viva, when we ask about parikartika, they start description of parivartika. See, both are different conditions. Parikartika is limited to anorectal disease, whereas parivartika is a paraphimosis, is a penile disease. So you should not get confused. So fissure definition will start. It is a crack in the longitudinal axis of anal canal. Most painful condition. Manifestation here, the cardinal signs, जिसको हम व्याधि प्रत्यात्म लिंग बोलते हैं. The one symptom which will make you spot diagnosis, and that is burning pain at the anal region. Patient will say that they will have pain at anal region while and after defecation, and many times this pain will continue for hours together, and the nature of the pain is like cutting, tearing and burning pain is so much that patient they are embarrassed and they fear to defecate. मोशन जाने की उनकी हिम्मत नहीं होती है, इतना पेन का डर रहता है उनको. सो इट इज द मोस्ट पेनफुल कंडीशन बिकॉज ऑफ द सोमैटिक नर्व सप्लाई एंड इट इज बिलो द डेंटेट लाइन. ब्लीडिंग इज नॉट द कंसर्न इन फिशर. फिशर में प्रोफ्यूज ब्लीडिंग नहीं होता है, ड्रॉप ब्लीडिंग नहीं होता है. देयर इज अ आइडेंटिकल ब्लीडिंग विथ स्ट्रीक्स ऑफ स्टूल. पेशेंट विल टेल यू दैट स्टूल के साथ लग के ऐसा एक धार दिखता है. सो दैट इज इनफ टू अंडरस्टैंड इट इज फिशर एंड नॉट हेमरॉइड. नाउ क्लिनिकल इवेल्युएशन इज वेरी डिफिकल्ट इन acute phase because it is the most painful and tender condition. But for chronic fissure, again there is a classical triad. That triad is hypertrophy anal papilla, presence of bed of ulcer and sentinel tag. If you go to the previous slide, here we have demonstrated the triads. Here you can see crack, that is fissure. This inside growth covered by mucosa is anal papilla, and outside having the skin covering is external sentinel tag. So presence of these three triads confirms chronic fissure in ano. About the gender here, now the ratio is completely changed. As in hemorrhoid, it was more, the male were more prone to get hemorrhoids, but fissure, females are more prone to get fissure. And the common locations for this fissure is if you divide the anal orifice into anterior half and posterior half, then the females tend to get fissure anteriorly at 12 o'clock. More than 70% cases in females they have fissure at 12 o'clock, whereas in male it is opposite to the posterior side at 6 o'clock. Now, most important thing in this slide is this bottom line. This is very important applied part of fissure, that we have discussed the standard common locations for fissure is 12 and 6 o'clock position. But if you notice fissure other than these standard positions, 10 o'clock, 5 o'clock, 3 o'clock, multiple fissures, then you should always give a thought of certain underlying pathology. It is not primary fissure, it is secondary fissure then. And which are the conditions which result into fissures are here. The Crohn's disease, ulcerative colitis, tuberculosis, HIV, malignancy, and most common nowadays, diabetes mellitus. Patient with diabetes mellitus many a times get multiple fissures. So if you know a person having diabetes, he is taking treatment from you say for 20 years, 30 years, and if he complains of such thing, you should always think that it is due to elevated raised blood sugar level. Now again, the etiology is divided into primary etiology, which are the true fissures, and the secondary etiology. So what are the primary etiological factors? Anatomical we know, trauma we know, anal infection, the most common thing, and constipation. These are the primary etiological factors for fissure management. Even in Sushrut, they have the concept of primary piles, primary parikartika, because Parikartika word was clearly mentioned while describing the prodromal features of Arsha. अर्श का पूर्व रूप जो बताया है सुश्रुत ने, उसमें एक टर्म है गुद परिकर्तन, which clearly mention the presence of fissure in the beginning stage of hemorrhoid. So that is primary piles, and then unsalutary lifestyles, constipation, then suppression of urge, vata prakopak ahar vihar, like nighttime awakening, diva stop and all, and then all these factors vitiate the Agni. The target is Agni only. And even, Sushrut has mentioned certain Ushna Tikshna drugs which can be correlated with the overuse of NSAIDs, higher antibiotics, and the steroids, even the anticides which actually neutralizes the acid, all they are responsible for Agni Dushti. So those are the primary etiological factors. Coming to the secondary etiological factors, in the modern books, you will find this Crohn's disease, ulcerative colitis, diabetes, HIV, leprosy. Those things give rise to secondary fissures. Even in Ayurved, they have concept of this secondary etiological factors like Jwara Upadrav, you will find Parikartika, Vataj Atisar, you will find Upadrav as Parikartika, Garbhini Vyapat, Parikartika. Most important, Sushrut 36th chapter, Basti Netra Vyapat Adhyay, where Sushrut has mentioned traumatic cause of fissure, Parikartika. So, and then Vaman Virechan Vyapad. So these are the secondary etiological factors mentioned in Ayurveda. In this one slide, as we have lot of things to cover in proctology, so the modern part I have tried to limit in this one slide, the management of fissure. Here, acute fissure onset is up to 4 weeks. If patient has complaints for say 1 day to 4 weeks, they are considered as a acute fissure, and then after 4 to 6 weeks, it is considered as the chronic fissure, which actually has the classical triad. Line of treatment is also different for acute and chronic here. For acute fissure, fiber supplement, stool softeners, more intake of water, local anesthetics, and along with the dietary and lifestyle modifications. So that is the line of treatment for fissure, acute fissure. Then there are therapeutic alternative for topical application. Some wonderful preparation in modern medicine is there. One is The nitroglycerin topical application ointments are there. G cream is there, which causes neurogenic relaxation of internal sphincter. Nifedipine ointment is there, which actually reduces the mechanical contraction of muscle, because pain in fissure is because of sphincter spasm. So that is relaxed. Deletism, all these you will find used in the cardiology practice also. So same medicine in a topical application form, deletism increases the blood circulation by vasorelaxation and it promotes wound healing. And then you very famous drug, Botox injection, we all know. Botox actually causes the chemical sphincterolysis. So these sphincters are released and pain is relieved. So these are the treatment alternative for acute and chronic fissure both. But my practical experience is that if patient is not responding to the standard line of treatment, the basic treatment, then and if he develops the sentinel tag, then you have to go to the surgical options only. And the best practice surgery nowadays is lateral sphincterectomy, having wonderful result in which we actually divide the fibers of the internal sphincter, which relaxes the sphincter, and simultaneously circulation is improved and the wound healing takes place. So that is the wonderful treatment. There is a lot of myth that it causes incontinence and all, but the statistics suggest this, that incontinence is very less, 1 to 1.8% cases may develop in incontinence. Coming to the Ayurvedic management. Now again, as we see the Nidan and the etiological factors, considering hemorrhoid and fissure, both have similar pathology. So the line of treatment is also same again, Deepan Pachan drug, Vatanuloman drug. You have to treat constipation, you have to give Raktastambhak drug if bleeding is significant. You can advise takra in their routine consumption. You can give light diet. Most important part is the last part of this, because in fissure we have got wonderful treatment plan. All these things, Matra Basti with the help of Yashti Madhu oil, which has been mentioned again in Basti Netra Vyapad Chikitsa Adhyay. So this Yashti Madhu oil, Matra Basti, 30 ml to 40 ml daily for 8 to 10 days will definitely help in, reducing the burning sensation as well as healing the wound. Then there are other preparations, like you can give Shatadhaut Ghrit also, Rakta Chandan Siddha Ghrit is wonderful drug, and Yashti Madhu Ghrit for local application, along with the Deepan Pachan Chikitsa and treatment for Vata vitiation. Role of Shara in fissure, again there is a controversy. Few of the Ayurvedic surgeons and practitioners, they are using Pratisaraniyak Shar in the bed of the ulcer, aiming at, they feel that this Shara will actually debride or perform the lysis of the fibrous tissue which is inside the bed of the ulcer. This fibrous tissue, they are responsible for non-healing of ulcer. So they say that this Shara application will definitely do the lysis of fibrous tissue, and which will increase the promote the healing part. But my suggestion would be, as the patient is always in the agony of pain and burning sensation, in that wound if you apply the Shara, that will create more discomfort to the patient. So we are not using Shara in the management of fissure. मैं एग्ज़ाम के लिए एक बार गया था एक गवर्नमेंट कॉलेज में. देयर आई हैव सीन अ थीसिस ऑफ मैनेजमेंट ऑफ फिशर with Shar Sutra, a very reputed known guide from our surgery fraternity. Solanki sir might be knowing it. So वो क्या करते थे, एक needle जैसा instrument बनाया उन्होंने, similar to the probe, और उसको फिशर बेड के पोस्टीरियरली एट्रोजेनिक ट्रैक बना के अंदर से निकालते थे एनस से, और फिर वो फिशर बेड पे टाई कर देते थे. सो देयर एम वाज लाइक, इससे वो धीरे धीरे फाइब्रस टिश्यू कट जाएगा, स्फिंक्टर भी डिवाइड हो जाएगा और पेन रिलीव हो जाएगा. बट एक्चुअली आई फाइंड इट इनह्यूमन, because I have never tried such things, and it don't have any scientific approach. Basically you should have a scientific approach to your treatment plan. So don't try that. Don't try Shar at all in fissure condition. Of course, for Agni Mandya, there is a Paniyak Shar combination Shankhavati mein hai, wo aap Shar internally de sakte, but not the topical application part. Guda Vidadi, only 2 slides because we are short of time and we have to cover the main Shar Sutra file. So, Guda Vidradhi, different types of abscesses. Most common is the istiorectal abscess, perianal abscess, intersphincteric abscess, supralevator abscess. The clinical manifestations ranges from the pain, high fever, swelling, tenderness, and pus collection in the perianal region. Treatment or the management of abscess, very simple. Gold standard treatment is incision and drainage. You have to incise the vranashot or the abscess, drain the pus inside, break the pus pockets, locules, and then you have to do vigorous dressing with the help of roller gauze packing from bottom to top, because you need healing from bottom to top. Otherwise, agar aisa nahi karenge, to upar se jakham bhar jayenge and there will be cavity left and that will reoccur. And the treatment is Hilton's method, isko bolte hain, in which we take a cruciate incision, criss-cross incision, and then the flaps of the skin are cut through. So that is the standard, gold standard treatment for abscess management. In Ayurveda, abscess again, treatment differs from the stage to stage. If the patient is coming with the unripen condition, agar wo pus formation nahi hua hai, that time you have to treat is as per the line of treatment of vranashot. व्रणशोथ अध्याय में जो चिकित्सा बोला है इन्फ्लेमेशन का, उसमें अपतर्पण, आलेपः, परिचको, अभ्यंग, स्वेदो, विमलापनम, जो पहले 12 षष्ठी उपक्रम के यह है, वो आप प्रैक्टिस कर सकते हैं. यू कैन यूज लीच एप्लीकेशन, यू कैन अप्लाई वेरियस मेडिसिनल पेस्ट लाइक वटपत्रादि लेप एंड दोज थिंग्स. बट इफ the abscess do not resolve, then the option is patan karma even in Ayurveda. And patan karma is nothing but incision and drainage of pus. So now we are coming to the interval is there, and now we will start with the main part of today's presentation. We will be discussing about the fistula, about Shar Sutra, and about my new invention for which I got patent. So in this part, we will be focusing on basic introduction about Bhagandar and fistula. You should know what is Bhagandar or fistula. We will be discussing about the established management, the modern surgery, and the Ayurvedic management, limitations of conventional management, and then my new invention, and then the scope of the new invention. So these things will be discussed in this part, which is the last part of presentation. So fistula in ano, again, this is the very common definition we get in any surgical textbook, that it is abnormal unhealthy tract which is lined by unhealthy granulation tissue, which has got 2 openings, the external opening in the perianal skin and the internal opening in the anal canal. So this tract is called fistula in ano. Now see the most comprehensive definition of Bhagandar. The similar disease mentioned in Ayurveda is Bhagandar. Fistula in ano is Bhagandar in Ayurveda. So the most comprehensive definition, see the beauty of Shushruta Samhita. Here if you read this slok as per Anvay, Tesham tu purva rupani kati kapala vedana kandu dahascha sofascha guda bhavanti. So Sushruta has mentioned the prodromal feature. Those who are prone to develop this condition will have this problem, like kati kapala vedana. So Abba knows that I was very average student, so when we were pursuing our graduation, जब हम वो पढ़ते थे तो हमको क्या लगता था, कटी कपाल यारे भगंदर में ऐसा पेन होता है कि कमर से लेके सर तक होता है. That was like lighter part of it. But if you go in micro teaching, kati kapal is a single word which denotes pelvic floor. So there will be discomfort in the pelvic floor. Patient will say कुछ दर्द जैसा अंदर होता है in the buttock region. Then there will be itching like sensation and there will be inflammatory changes. So that is Purvarup, and in the beginning patient will develop a boil that is called Bhagandar Pitika, and if it is not treated properly, it will burst on its own and convert into a discharging tract, and that discharging tract is known as Bhagandar. So most comprehensive definition we get in Sushrut Samhita. This the same thing, the pathogenesis in Sushrut, I have tried to make in a flow chart manner, that due to indulgence of unsalutary lifestyle and food habits, vata get aggravated, localized into the anal canal, then they vitiate the rakta and mausa dhatu, and then it give rise to a boil or pitika, and if it is not treated, it will be bursting and converting into a discharging tract. The modern etiology, basically they have divided etiology into the what you say, non-specific causes and specific causes. Non-specific causes are actually developing the true fistulas. जो सही में fistula है, that is because of these non-specific etiological factors like cryptoglandular infection. There, exist anal glands in the columnar anal canal at the level of dentate line. So that gland is a part of lymphatic chain of our body. So the basic pathology starts from there. They get inflamed, infected, and pus is formed, and that pus is transported outside to the perianal region. So that is the main cause of all type of Bhagandar here. And then the complication of anorectal abscess or even the previous pyogenic infection, they can result into fistula. Now what are the specific causes? Here are the secondary causes, when there is an underlying pathology which give rise to fistula, like tuberculosis, anal fissure, colitis, carcinoma, foreign body trauma, the patient who are into the who are exposed to the radiations frequently, CA, pelvic inflammatory diseases, all these are the secondary causes of Bhagandar. Now again, see here we have seen the pathogenesis as per Sushrut. Now here we have discussing about Charak Samhita. Basically जो शल्य के team hai, usually they don't refer Charak Samhita because they say they are Adya Granthi Sushrut. But you see the beauty here in Charak Samhita, though he has not mentioned a separate chapter on Bhagandar, but in Shvayathu Chikitsa Adhyay, he has mentioned this pathogenesis of Bhagandar wonderfully, and there he has given various etiological factors for Bhagandar like Krimi Bhakshan. Now Krimi Bhakshan is the clear indication that our wisdom of those ancient rishis, they were knowing about the cryptoglandular infection. That is Krimi Bhakshan, the microorganism into the causing Bhagandar. And then Astrina Astikshanan is traumatic Bhagandar. Pravahan again, Pravahan is not like dysentery only. Pravahan is any strenuous work which is seen as colitis, ulcerative colitis, Crohn's, IBS. Those patients will be more prone to develop Bhagandar. Then Utkatasana, sitting on hard surfaces, uneven surfaces for longer time. And then, Utkat Ashwa Prishtha means those days the mode of transportation was like horse riding and an elephant riding. So they were used to get Bhagandar. Now here we can correlate with the people who are into over motorbike drive. So these people are also prone to get fissure, because if you see in detail pathogenesis, those people who sit for longer time on hard surfaces, there is a microischemia in the cells, and that will result into inflammation, infection, abscess, and Bhagandar. So this is about Charak Samhita. Coming to Vagbhat, very wonderful, because I always keep this slide whenever I present a topic on Bhagandar. Now the basic etiological factors are same: horse riding, sitting on hard surfaces, squatting posture. But what Vagbhat has given, two distinct etiological factors, very difficult to understand. One is maturing of sinful act of previous lives. This is, they say that पूर्व जन्म में किए हुए गलत कामों के वजह से Bhagandar हो सकता है. So it is very difficult to justify how, I mean, you cannot make such statement. But even in modern texts, you will find one of the cause as cause of unknown etiology. जो बीमारी उनके समझ में नहीं आता है वो बोलते हैं द कॉज इज अननोन एटियोलॉजी. सो यू कैन कोरिलेट दिस विथ पूर्व जन्म वाला पार्ट. एंड देन अनदर पार्ट इज वेरी इंपॉर्टेंट, दैट इज अब्यूसिंग एसिटिक्स. अब इसका सिंपल भाषा में अगर आप ट्रांसलेट करेंगे तो इसे हम कहते हैं गुरु निंदा. तो मैं जब पढ़ाता हूँ बच्चों को, और डेफिनेटली बच्चे बाहर जाने के बाद कुछ को पसंद आता है, अभी ये लेक्चर सुनते समय भी किसी को बोर हो रहा है, अरे यार क्या पका रहा है सर, तो ऐसे लोगों को मैं कुछ पनिशमेंट नहीं दे दूंगा, बट जो गुरु निंदा करते हैं उनको ऑटोमेटिकली दे विल डेवलप भगंदर. ये ध्यान में रखना, आगे से आपके शिक्षकों के लिए अच्छा रहेगा. So that is about abusing ascetics, that has been given as one of the cause for Bhagandar. Well, the classification, there are various classification. Most practiced classification is Milligan-Morgan method, which is like 5 types: submucosal, submucous, low anal, high anal, and anorectal fistula. And the other is based on the involvement of sphincters, that is intersphincteric, transsphincteric, suprasphincteric, and extrasphincteric. These are the classification. Now again see the beauty of Sushrut Samhita. Sushruta has classified Bhagandar based on causative vitiated dosha, considering the consistency of discharge, the smell coming out, the number of openings, and the anatomical appearance of Bhagandar. So considering all these things, Sushrut has given these 6 types: Shataponak, Ushtagriv, Parisravi, Shambhukavarta, and Unmargi. Shataponak is having fistula with multiple openings and ramifications. Ushtagriv, the course of the tract will be like neck of camel. जो ऊंट के गर्दन होती है वैसा कर्व उसका कोर्स होगा. Parisravi having profuse discharge as we see in tubercular abscesses. Shambhukavarta is something anterior or posterior horseshoe fistula, and Unmargi is due to the traumatic origin. Coming to Charak and Vagbhat, Charak has almost similar categories like Vataj, Pittaj, Tritosas and Kshataj. वाग्भट ने यहाँ पे 3 अलग टाइप्स ऐड कर दिए हैं, दैट इज परिक्षेपी भगंदर. परिक्षेपी मीन्स हैविंग वेरी लॉन्ग कोर्स ऑफ ट्रैक. मतलब एक ओपनिंग आपका अगर पेरिएनल रीजन में, तो दूसरा ओपनिंग पेल्विक फ्लोर में भी हो सकता है, ग्रॉइन में भी हो सकता है. सो दैट टाइप ऑफ फिस्टुला इज परिक्षेपी भगंदर. देन रुजु भगंदर एंड अर्शो भगंदर. नाउ इफ यू सी द बॉटम लाइन हियर regarding the prognosis of Bhagandar, all our classical texts, they says that all type of Bhagandar are difficult to treat. आसान नहीं है उनको क्योर करना. हर एक, उसका मतलब क्या है कि रिकरेंस के चांसेस हो सकते हैं. एंड देन Shambhukavarta and Unmargi are, they have considered is more difficult to treat. This is about the evaluation or diagnosis of fistula. We can skip it. We know the probing test is done in which the probe is introduced from the external opening and allow it to follow the track. That is the way you can see the depth and direction of the fistula. In the cases where you find recurrent fistula, always try to do pus culture and antibiotic sensitivity test to select appropriate antibiotics. Radiologically, in our times, we had only one option, that is fistulogram. But now they are having wonderful diagnostic tool, MRI, which actually gives the minute ramifications. एकदम अच्छे से वो कितना डेप्थ है, कितनी लेंथ है, कितनी ओपनिंग है, कितना ramification, everything is clear with the help of MRI. Coming to the maybe last part of presentation, the treatment alternatives what you have. Modern surgery, fistulectomy, gold standard. If it is having internal opening is not accessible, then they do the sit-on ligation to it. Then previously people were using anal fistula plug, fibrin glue, but these are outdated now because of the high recurrence rate. Lift, waft and laser, these are the most practiced treatment techniques, surgical techniques. Lift is ligation of internal sphincters, internal opening of the fistula tract. Waft is video assessed anal fistula treatment, and laser, we all know it is delivering the heat and coagulation of the vessels there. Then in Ayurvedic treatment, we have got options, wonderful parasurgical procedure mentioned in Ayurvedic classics, that is Shara Sutra therapy. Now there in Shara Sutra therapy also they have modified as per the convenient and experiences, reducing the time span of the treatment. Like IFTAC is a wonderful treatment, interception of fistula tract and application of Shara Sutra, and then partial fistulectomy with Shara Sutra ligation. So these are the little modifications in conventional Shara Sutra therapy. That was a video of fistulectomy. I think we can skip that. We will go to the Chikitsa mentioned in Sushruta Samhita. So Sushruta says, again, if patient is coming in early phase with Vranashot or Bhagandar Pitika, the treatment is conservative management. But Sushruta himself says that if the पेशेंट इज कमिंग विथ एस्टेब्लिश्ड भगंदर, अगर वो ट्रैक है उसका वहाँ से डिस्चार्ज हो रहा है तो डायरेक्टली भगंदर मुखम आसाद्य एषणिम दत्वा शस्त्रम पातयेत. इवन सुश्रुता सेज दैट यू हैव टू डू फिस्टुलोटॉमी, मीन्स यू हैव टू टेक incision on the track with the help of fistula probe and then let the wound heal by its own. So that is the direct treatment given in Sushruta Samhita. Again, you know, when I was pursuing my post-graduation, there was a task given to me that find out where Sushruta has given Shara Sutra for Bhagandar. तो हम लोग अपना बहुत आसान टास्क है, अपना ढूंढ रहे सुश्रुत संहिता, भगंदर निदान, चिकित्सा, कहीं पे भी श्वार सूत्र का वर्णन नहीं किया है सुश्रुत ने in context to Bhagandar. But we get indirect reference of use of Shara Sutra in Sushruta Samhita while describing Nadi Vrana Chikitsa Adhyay. In Nadi Vrana is sinus. It is similar to fistula, but the internal opening is blind. So in that condition, Sushruta has said use of Shara Sutra for excision of that tract. So that is the indirect reference we get about use of Shara Sutra in Bhagandar Chikitsa in Sushruta Samhita. What is most important here is to, you know, limit or restrict the recurrence rate. What we are doing is we are simply doing fistulotomy and fistulectomy and keeping the wound to heal. But what Sushruta has said is after the fistulotomy, you have to apply Shar in the bed of the ulcer. That will definitely reduce the chances of recurrence. Or two options he has given. Either you put an pratisharanic Shar in the bed of the ulcer or cauterize the wound. Even cauterizing the wound after fistulotomy will reduce the chances of recurrence. तो ये part हम लोग पढ़ते नहीं हैं. Further, in our day-to-day practice, those who are into serious proctology practice, we find certain cases where the track of the fistula is not patent. मतलब वो internal और external opening के बीच में obliteration रहता है, चिपका गिरी रहता है, तो वो पस पूरा बाहर आता नहीं है, even probe भी अंदर जा नहीं सकता है because of the fibrosis. So in those cases, Sushruta has given a wonderful guidance that in cases where the track of the Bhagandar is not patent, you can practice certain medicated oil irrigation. Sawantwadi तेल, भगंदर नाशन तेल, ऐसे कुछ medicated oil है which is having lekhan property. Those oils can be irrigated from the external opening for 3 to 5 days, and that will definitely help in opening the track. So that is the guideline given. This is the shlok, you know, in the Visarpa Nadi Stanarok Chikitsa Adhyay, where we get उन्होंने ऐसा बोला है कि those who are not fit for surgery of sinus, maybe pilonidal sinus, so in those cases you can excise the sinus with the help of Shara Sutra. And in the second line Sushruta says Bhagandare api esha vidhi karyo vaidya ne janta. In this similar line you can use Shara Sutra for management of Bhagandar. Coming to Charak Samhita. Now again मेरा ये जो धारणा था कि सुश्रुत शल्य वालों ने सिर्फ सुश्रुत ही पढ़ना चाहिए, ऐसा नहीं है. एज वी हैव सीन अ डायरेक्ट रेफरेंस ऑफ भगंदर इन श्वेथु चिकित्सा अध्याय, हियर अगेन इन चरक संहिता वी गेट अ डायरेक्ट रेफरेंस ऑफ यूज ऑफ शार सूत्र फॉर भगंदर मैनेजमेंट. सुश्रुत ने इनडायरेक्टली बोला है नाड़ी व्रण में करते हैं इसलिए भगंदर में भी करो, बट चरक ने डायरेक्टली बोल दिया है स्यात् शार सूत्रेण सुपाचितेन छिन्नस्य च अस्य व्रण चिकित्सा. आफ्टर excising the fistulous tract, you have to treat the wound as per the line of treatment for wound management. Chakradatta again Chakradatta has the similar line of treatment as Sushruta has said, that in the Vranashot stage you have to treat conservatively, and if the track is established then you have to do the Patan Kriya. Vagbhat again Samyak Shastrena Pate, directly fistulotomy. But if you remember, Vagbhat, while giving the classification or name of various types of Bhagandar, he has added 3 types: Parikshepi, Rujugranthi, Arsho Bhagandar. So, while describing treatment of Parikshepi Bhagandar, even Vagbhat has directly mentioned use of Shara Sutra. Parikshepine cha epi eva nadi yuktah Shara Sutra ka hai. That is the quote given in Vagbhat. So, Vagbhat has also given a direct indication of use of Shar Sutra for management of Bhagandar. Again, Bhaisajya Ratnavali, we get same references. We get the reference of Shar and Shara Sutra Nirman in Bhaisajya Ratnavali and Rasa Tarangini. So the curiosity is, what is Shara Sutra? If somebody who is not from Ayurved and he listens, says, okay, bhai, kya hai Shara Sutra? So here few slides are for orientation purpose, what Shara Sutra is. I know most of the practitioners and those who have graduated, they know about the Shara Sutra. So how you can define Shara Sutra? It is, Ayurvedic medicated thread coated with herbal alkaline drugs. That thread is known as Shara Sutra, and which is basically meant for fistula and sinus ablation. I have purposely put these 3 images, Sanghvi sir का Shara Sutra है, जो हम आपके यहाँ से purchase करते हैं. Then Dhuri Sahab ने introduce किया है. Then Shara Sutra is available even in the airtight test tubes. So these are the various available Shara Sutra in the market. And this is the composition of Shara Sutra. We can definitely skip. This is standard Apamargak Shara Sutra, conceptualized by late Dr. P.J. Deshpande, who was working in Banaras Hindu University. Sanghvi sir और आप लोगों ने बहुत काम किया है वहाँ पे. So ये स्टैंडर्ड शार सूत्र है जिसको ICMR ने भी रिकॉग्नाइज किया है. ICMR ने आयुर्वेदिक फार्माकोपी ऑफ इंडिया में स्टैंडर्ड शार सूत्र के प्रॉपर्टीज मेंशन कर दीजिए हैं और उसके प्रिपरेशन मेथड भी बताए हैं. एंड दैट इज एज पर डॉक्टर पीजे देशपांडे सर, जो बार्बर थ्रेड है उसके ऊपर कोटिंग इन अ स्पेसिफिक ऑर्डर, टोटल 21 कोटिंग्स. द इनर मोस्ट कोटिंग इज ऑफ स्नूही, देन alkaline ash of apamarga, and then the haridra powder. So this is the preparation methodology of Shara Sutra. इसमें मेरा कुछ नहीं है, जो शास्त्रों में दिया है और जो लेट डॉक्टर पीजे देशपांडे ने जो एक कंसेप्ट बनाया है उसके हिसाब से ये कोटिंग और उसका प्रिपरेशन मेथड है. This is what I was discussing in the Ayurvedic Pharmacopoeia of India. So what is important in this table is gauge of the thread should be 14 to 16. Length of the thread variable maybe from 10 centimeter to 30 centimeter. Diameter or thickness is very important. 1.75 mm to 2 mm. That is the diameter of Shara Sutra. Tensile strength should be ब्रेकिंग लोड ऑफ 5 kg, यानी 5 किलो का सामान अगर वो शार सूत्र पे बांधेंगे तो वो टूटना नहीं चाहिए, उससे ज़्यादा एक्सीड होगा तब वो ब्रेक होगा. दैट विल बी दी टेंसाइल स्ट्रेंथ. एंड पीएच रेंजेस फ्रॉम 9.3 टू 10.5. दैट इज द स्टैंडर्ड फिजिको केमिकल कैरेक्टर्स, द गाइडलाइंस गिवन बाय ICMR. नाउ दी कन्वेंशनल शार सूत्र, इस पे भी हम ज़्यादा डिस्कस नहीं करेंगे. हमको पता है कि शार सूत्र कैसे बांधा जाता है. आई एम हैविंग अ स्मॉल वीडियो क्लिप ऑफ दैट. बेसिकली यू रिक्वायर एन मेलिएबल मेटल प्रोब which can be of copper, silver or panchadhatu, which is the shape is like needle. it will have an opening at one end, the rear end. जैसे सुई में हम धागा embed करते हैं वैसा ही क्षार सूत्र बांध देना है उसमें, and then this probe is introduced into the external opening of the fistula and it is allowed to follow the course of the tract, and once it reaches the internal opening you will be taking it out from the anal canal, and while doing this automatically the Shar Sutra is placed in the track of fistula. So that is how the Shar Sutra therapy is done. External opening at 7 o'clock, small low anal fistula, then the probe is introduced, having embedded the Shar Sutra on the rear end, then it is taken out from the internal opening which is very much adjacent to the anal orifice, and the probe is malleable, so you can let it malleate it and take the probe outside from the anal canal, and while doing this automatically Shar Sutra is placed in the fistula tract. This is very simple procedure and most of us have witnessed. I know the Sion Shalya department, they are functioning very much and they are using Shar Sutra for where it is advised. Now here if you see in the clip they have done little tightening of the thread, but this actually because the patient wants they don't have time to multiple sittings, so you can tight it little hard. But ideally the thread should be not very tight, not very loose. So this is Shar Sutra therapy. बहुत आसान है, BAMS लेवल पे भी कर सकते हैं. हमको महाराष्ट्र काउंसिल ऑफ इंडियन मेडिसिन ने परमिशन दिया है कि BAMS लेवल पे भी आप शार सूत्र कर सकते हैं. बिकॉज देयर वाज अ केस ऑफ डॉक्टर दाहापुते इन भिवंडी. ही वाज कॉट फॉर प्रैक्टिसिंग शार सूत्र. ही वाज प्लेन BAMS. The people there, authority, they were saying that you are not having master's degree, so you cannot practice. But that time the council has given a notification that yes, we allow our Ayurvedic practitioners to do the Shar Sutra therapy. So these are the advantages of Shar Sutra. We all know that less recurrence rate, simple procedure, time conserving, there is no direct damage to the sphincter, early immobilization, no need for proper anesthesia, hospitalization, all this. अगर इतना सारा एडवांटेज and even if you see the Central Council and Ayush Department, RAV, they are giving funding for 6 days CME for Shar Sutra. यानी उनको ऐसा लगता है कि शल्य तंत्र मीन्स शार सूत्र और कोई ब्रांच उसमें उनकी स्पेशलाइजेशन नहीं है. अगर इतना कुछ है तो फिर शार सूत्र ग्लोबलाइज्ड क्यों नहीं है? Why the modern surgeons are not accepting it as a standard line of treatment? So while discussing this with my senior colleagues, I have found certain causes why Shar Sutra is not globalized. What are the problems in the globalization of Shar Sutra? So first is there is no standard SOP for Shar Sutra therapy. पंचकर्म की थेरेपी अभी अभी बन गई, आपने देखा होगा. when from the culture of NABH you have to prepare an SOP for every procedure. But even nowadays there is no SOP for Shar Sutra therapy. No uniformity and standardization in the probe design. जैसा मैंने बोला कुछ लोग कॉपर का प्रोब बनाते हैं, कुछ सिल्वर का, कुछ पंचधातु का. दे हैव डिफरेंट मैलिएबिलिटी. उसका थिकनेस कितना होना चाहिए, लेंथ कितना होना चाहिए, कुछ भी मेंशन नहीं है. Then doubtful sterilization of the available Shar Sutra, that is also concern. Ordinary packaging, storage and poor availability, most important thing. अगर आप प्रैक्टिस कर रहे हो और आपको शार सूत्र चाहिए, मुझे नई मुंबई से संघवी साहब के पास आना पड़ता है. So poor availability is also one of the problem. Then poor acceptability by modern surgeons because of lack of training, lack of documentation and fear of complication. ये जो इमेज दिया है ये भी किसी ने शार सूत्र ही कराया है. देखिए वो सेप्टिसेमिया तक के पेशेंट की डेथ हो गई because of lack of training. Then lack of awareness in the population, and most important again here the last line. I will emphasize this thing. This is also main factor for not globalizing the Shar Sutra treatment, because in society find Chansi Dawakhanas, the Madar clinics, Bengali healers. 80% cases of anorectal problem, consult them. Because of the illiteracy, because of their having a agent network, बस डेपो पे, रेलवे स्टेशन पे, हॉस्पिटल के बाहर उनके एजेंट्स रहते हैं और वो आपको पूछेंगे क्या हुआ है, भगंदर हुआ है, अरे वो हमारा वो बंगाली डॉक्टर है, वो बहुत अच्छा ट्रीटमेंट करता है. देन ही इज मोटिवेटेड, डाइवर्टेड टू दैट Madar clinic or whatever. So, ye log, they are not institutionally trained, they are not doctors, they don't have any scientific approach and knowledge about the condition and management, and they are actually spoiling the name of Shar Sutra and even the Ayurvedic surgeons. So, these are certain problems which are, I have mentioned, which are responsible for not globalizing Shar Sutra. So, what are the limitations in Shar Sutra? Again, it is practice is limited to the Ayurvedic Medical College and very few practitioners. संघवी साहब का मैं बार बार नाम लेता हूँ कि उन्होंने बहुत अच्छा काम किया है कि कम से कम बहुत बड़ी एक ट्रेंड डॉक्टर की सिस्टम बनाई है, आयुर्वेद प्रोक्टोलॉजी एसोसिएशन उन्होंने बनाया है और उसमें एटलीस्ट दे आर ट्रेन्ड इनटू, साइंटिफिकली ट्रेन किया जाता है उनको एंड दे आर यूजिंग इट, बट द नंबर्स आर वेरी लेस. मेटल प्रोब जो हमने बताया, इट इज क्वाइट हार्ड एंड देर इज ऑलवेज चांस ऑफ एट्रोजेनिक ट्रैक फॉर्मेशन बिकॉज ऑफ दिस मेटल प्रोब. देन possibility of contamination of Shar Sutra during procedure, and most important, those who are practicing Shar Sutra, कई बार अगर transsphincteric fistula है तो probe डालते समय patient goes into sphincter spasm और फिर वो जोर दे के प्रोब को आपको बाहर निकालने पड़ता है. सो ड्यूरिंग दैट प्रोसीजर देर इज ऑलवेज पॉसिबिलिटी ऑफ स्लिपेज ऑफ शार सूत्र, यानी शार सूत्र एनल कैनल से बाहर आ जाता है, सॉरी प्रोब, और शार सूत्र दूसरे एंड में रह जाता है. एंड ड्यूरिंग दिस प्रोसीजर इवन द कोटिंग इज वाइप्ड ऑफ, जो शार सूत्र की कोटिंग है वो भी पूरी निकल जाती है. सो दोज आर द लिमिटेशंस इन द करंट शार सूत्र थेरेपी. And there is no assurance about the manufacturing details, its cost, its physiochemical properties, उसकी sterilization का कोई guarantee नहीं है जो available शार सूत्र है. So ये सब problems है and even the availability is the big problem. तो इसका answer क्या है? Answer is my small effort in standardizing Shar Sutra therapy. The answer is Shar Sutra carrier cum application device. So what is this invention about? This device is a disposable, malleable and flexible tube made up of HDPE material, health graded material, and having internal diameter of 1.85 to 2 mm and outer diameter 3 mm. This length of the tube is ranging from 8 to 30 because when you file an application for granting patent, you need to give the ranges. अगर मैंने 10 सेंटीमीटर का डिवाइस बनाया, किसी ने 15 का बना दिया तो बोलेगा उसका है. So you have to give a range. Then Shar Sutra prepared by standard method having thickness of 1.8 or 1.75 mm after UV treatment is embedded in this sterile device itself. यानी इस ट्यूब के अंदर शार सूत्र है, and then after putting the Shar Sutra inside, front and rear caps are fixed and this device is kept into sterile airtight pack, and on the envelope or on the packaging you will find the physiochemical characters of it, manufacturing details, indications. अभी मैंने कुछ शार सूत्र का एक नया किसी ने बनाया देखा तो इंडिकेशन इज पाइल्स फिशर फिस्टुला. अरे पाइल्स फिशर फिस्टुला कैसे हो सकता है? तीनों अलग बीमारी है, तीनों की ट्रीटमेंट अलग है. सो द एग्जैक्ट इंडिकेशन इज मेंशन्ड, इवन द कॉस्ट पार्ट इज लेबल्ड प्रॉपरली on the cover itself, and this was the design submitted, the prototype. So methodology of using this device for Shar Sutra therapy, मैं ये पढ़ूंगा नहीं. We will directly go to the actual procedure of Shar Sutra therapy with help of this new device. So the concept of this device was started in 2012. I have filed this for patent in 2012. It took around 10 years to grant the patent. So here you can see this wonderful device, and the same speculum I am using here because I wanted to show how it is taken out from the internal opening. So this is just for visualizing the anal canal. Otherwise, this step can be skipped off. No need to put sim speculum. Now here you can see here, there is an external opening at 11 o'clock. You will appreciate here. Making sense? And then this device introduced, taken out, and here you will remove the flaps, the closure measures. The front cap is conical and rear cap is flat. So after removing the closure flaps, you have to hold the Shar Sutra with the help of mosquito artery forceps and withdraw the device from outside only. No need to take it out from the internal anal canal. See. And that's it. You know, Shar Sutra procedure is done. So this device will definitely help in smooth application of Shar Sutra. This device is a storage device as well as it will be helpful in drug delivery system. This is how you have to present that it is a storage device come drug delivery system in which the Shar Sutra is ligated. So Shar Sutra procedure is done. So salient features. अरे कश्मीर फाइल जैसा ये शार सूत्र फाइल नहीं है, आप लोग इतना ये नहीं करें. It is a small effort to standardize Shar Sutra therapy and make it an established treatment. So these are the salient features. It is, you know, advanced sterile disposable device meant for fistula and sinus ablation. It is user-friendly device, you will appreciate. Application procedure is time conserving. No instrument and probe is required, so no chances, the minimum tissue handling is there, and procedure will be ambulatory procedure. No chance of slippage of Shar Sutra, no chance of coming off of the coating of the material. So this Shar Sutra carrier cum application device will help in the globalization of Shar Sutra technique for fistula management, and this will be definitely acceptable to the modern surgeon always. So this is the end, the last slide of this. I fought for 10 years to get patent of this instrument. 2012 set, 2021, 12th October. The final hearing took place around 2.5 hours to convince the commissioner that it is an innovative approach. And the news was covered with all the leading newspapers, right from Times, Indian Express, even few channels. They have appreciated this work. And with this, I conclude my presentation, giving my special thanks to these two dynamic personalities I have ever met. One is Dr. G.S. Lavekar, who was former Director General of CCRS. When I was pursuing my post-graduation, he was head of department there, wonderful person. And Lahankar ji ko pehchan ki zarurat nahi, everybody knows about him. Dr. M.A. Lahankar, former registrar of Maharashtra University of Health Sciences, who was, who has taught me life engineering, how you have to be like that. So he has a great impact in my life. And along with these two stalwarts, I thanks the Mumbai Vaidya Sabha officials, the office bearers, the managing trustee, and all the dignitaries present here who has given this opportunity to present my work. And with this I conclude. Thank you one and all.
So, for this wonderful session, our concept related to proctology have truly been redefined, and I'm sure our knowledge has been very well updated, especially about Shar Sutra. It was definitely an extraordinary and valuable lecture for all of us. Thank you so much, sir. Now, I would like to request respected Ranjit Puranik sir, the President of Ayurved Prasarak Mandal, to felicitate Dr. Amar Dwivedi sir. I would again request respected Ranjit Puranik sir to give take-home message.
In 2 years, I think a lot has changed. This program used to be predominantly in Marathi. I used to be the only English speaker. And in 2 years, we see this massive colonization, if you want to call it. That apart, I think it's a great pleasure that we've started physical meetings again. I hope this continues lifelong and we never ever have to bring any kind of stoppage in our physical meetings as such. It's been an absolute treat to listen to something that is creative, innovation, experiential, an absolute application of wisdom that Professor Amar Dwivedi ji has talked about. His experience certainly shows. It goes deep into a very, very ardent application of his knowledge. His great determination to get a patent for something that he believes is his creation is a rarity because, and I can understand that his struggle was for 10 years. But it's very important for us to know that our science can only progress if there is innovation and there is creativity going forward. Government of India, Ministry of Ayush also recognizes this. In 3 weeks from now in Ahmedabad, the Prime Minister is going to meet our entire sector. He's going to be talking about startups that should emerge within the Ayush sector. He's going to talk about innovation and creativity. It's a very large function organized, not only to talk about creativity and innovation, but also to talk about, to celebrate the establishment of the traditional center that is being set up in collaboration with WHO. If there is many things that we appreciate about modern medicine, antibiotics of course, surgery is a very giant leap in sophistication of medical health care that we see. So that is certainly something that they have been able to contribute. But we must understand that in the realm of surgery, the seeds to modern surgery are very much within the thinking and the ambit and the process that is documented in our own pharmacopoeia. Last year, if I'm correct, no, maybe a year before that, it has been clarified the entirety of the legal meaning of a surgery qualification as given in the MD exams by CCIM at that time, no, NCISM at that time. And this entire enabling clause, this entire clarificatory documentation that was given, I think by all surgeons in Ayurveda, we need to appreciate what Government of India has done. And I'm sure Dr. Dwivedi as well as Dr. Vaidya Gupta ji would have realized the kind of vagueness that existed for very many years as far as a true recognition of an Ayurvedic surgeon. This is a sector that needs to be evolved, needs to be developed. It starts with a great amount of historical documentation. If you talk about Acharya Shushruta and you talk about the very many surgical instruments that he had, I think almost every college must display the whole gamut of such kind of instruments that have been described by Acharya Shushruta. We should not only have a collection of such instruments, probably remolded in fiber or plastic or maybe even steel, but in fact, Dr. Dwivedi and Vaidya Gupta, we should even start a patent fight with American companies who have patented Acharya Shushrut's wisdom and are probably collecting huge amounts of revenue without any obeisance to Acharya Shushruta. So it's one thing to receive lip service in terms of obeisance, and it's something else to give credit where it is due. And innovation and creativity is precisely that. Innovation and creativity is giving credit where it's due. Yes, Ayurveda is a nationalized repository of knowledge. Yes, it is an open domain, open source, but there is still plenty that can be done, can be patented, where individual scholars can, with applied principle, have this kind of creative, innovative kind of approach and even be recognized in times to come. Congratulations, Professor Dwivedi ji. It is in many ways, it's certainly your fight for a decade to get that, but most importantly is it has to serve as a spark to all the young doctors assembled here and all that who will see a YouTube of this entire presentation that you've given. And this is something very important, because in our sector, it is said that there is no research grants and no funds that come to our sector. And the reason that there is no R&D and there is no research grant is because there is no intellectual property that is worth patentable. Your particular endeavor paves the way and shows that certainly it can be done, it can be taken forward, and let's look forward to many more things that we can actually patent and take forward. A patent is, to me, of course, a patent needs to be encashed, commercially monetized, and it gets into all other kind of complications. But as far as this particular endeavor of Dr. Dwivedi goes, I think it's very important to recognize that as a scholar, his name is inscribed on that device. And I think that is certainly a certification, an accreditation, a recognition of his entire wisdom. I urge even this campus to take a look at very many things that can be done. I remember last year, between wave number 1 and wave number 2, there was a small program held in the Hassan campus, where an MD student had come out with these very handmade, hand-stitched cloth masks, but she had coated them with tamra bhasma, with some imagination that there will be a first barrier, a first safety barrier that the wearer will experience. Now, such and like kind of innovations, whether she's right or not, could be very many, and it could be an analysis that can be done. But please understand the spark. Please understand the creativity flair. And I think this younger generation, by the way, Dr. Dwivedi, there are not 3 generations, there are 4 generations today in this entire room. And I think what's very important is that the generation that graduates right now, the younger doctors who certainly have under them 5 or 10 years of experience, I think we need to look at such kind of innovation and creativity and take it forward, because India is evolving. India has certainly been recognized. Today, India is not a developing country. It is being recognized as almost a developed country. We have a long ways to go, but at the same time, our intellectual prowess, our ability to deliver, our ability to take care of our own is today established. And as a result, I think all things Indian are very much poised to go global, and these are things that we can do. Once again, to my entire colleagues in the college, as well as Mumbai Vaidya Sabha, we do thank you once again for venturing out and making this a physical meeting, and let's look forward to many more. Thank you.
Thank you so much, sir, for your valuable words. Moving forward, I would like to request Dr. Rajeshkumar Gupta, sir, President of the function, to present his presidential speech.
Respected Shri Puranik ji, Dr. Sharma ji, Dr. Dwivedi, माझे मित्र डॉक्टर नाबर, डॉक्टर सातपुते आणि आपण इथे उपस्थित विद्यार्थी मित्रांनो, मला वाटतं मी आज खूप वर्षाने इथे या कॉलेजमध्ये आलेलो आहे आणि माझा ह्या संस्थेशी संपर्क मी कॉलेजमध्ये शिकत असतानापासून आहे. थोड्या वेळापूर्वी मला डॉक्टर मावळणकर होते, गेले वाटते. I think he must be the senior most person who has attended this program today. And yeah, Dr. Kamath is also there. So my relation with this institute is quite long, almost 40 years. And I have seen this institute coming up from its very shabby structure, where I used to always imagine, that how these people are going to teach and practice Ayurveda in such an area. Please don't mind my words, actually. And I have my friends, Ashanand, Nabar, they know that we used to fight out actually. And I well remember that, in those days when we fought for that equal status. So that was actually turning point in the history of Maharashtra. Actually. Otherwise, this, what you see today, at least in Maharashtra, that is all because of that all the colleges in Maharashtra came together. And Sion was the key here. At Podar we had a big campus, we used to have meeting, we used to have everything, but Sion would remain the junction where we forced the government. Because this was the entry point into Bombay. No doubt we took political help in those days. We had a very long strike in those days. And we literally forced the government to see that we get equal status. So I thank all those students in those, my colleagues, friends, the college office bearers, those who came forward and helped us. And now you see this beautiful structure coming up in this campus. I think this can be still more beautified. I have seen those struggle days in this institute where they were trying to come out somehow. At one stage, I think it was almost closed. And in those days, I remember when I was working with Dr. Nagaral, he used to tell us about this institute because he was appointed by the government to see how this institution can be saved. Because I well remember talking with him that he told that, the government had already denied. The university had denied permission to the college. But then, as usual, Dr. Nagaral was a very key in seeing that the institute didn't get closed down. And then everything started moving, things started changing, and then you see now what it has resulted in a very fine institute now. So this is my association with this institute. I also well remember, I used to come to play volleyball in this college. And I think that was a time when these all friends came together. So play is also a part of our career which helps us to build ourselves. And I'll tell you, my career as a surgeon, as an Ayurvedic surgeon, started from not knowing what is Ayurveda. When I was put into the Podar college on my daddy's interest, when I first reached the college, I had a very surprising thing, the things were being delivered in Hindi or Marathi. I was a convent student. So I was a little bit disturbed, how to hear these lectures in the Hindi and Marathi. And after a week, I went to my house and told my daddy that it's not possible for me to learn. So my daddy told, you just somehow spend 1 year in the college. If you feel like accepting it, accept it, or that you join the college. So this is how I started from a no to this Ayurveda, and I have reached a career now at where, even after my retirement, still I am continuing. So it's very fascinating, that, I started a career where somehow the degree was given to me, whatever my things were there, 7.5 years course, such a long course. All used to ask me, आप 7.5 साल क्या पढ़ोगे करके. And it was a really question that what to do. Then it became 5.5 years. So this has been a long journey, for Ayurveda in India, where it started from short courses, a very lengthy courses, and I think Dr. Pandit Shiv Sharma was the key person who brought CCM into picture, and first time in 1971 the Parliament Act was passed and we all are what we see today. But he did the prime thing. Later on the things didn't change, I'll tell you. See, 71 and today it's almost now more than 50 years, I'll tell you. And as rightly pointed out by Dr. Puranik, this is the first time in history of Ayurveda in India, I'll tell you, that the PMO office has taken efforts to give recognition to our community, I'll tell you. And I'll tell you, the amount of budget sanctioned for Ayush is beyond imagination. I well remember 20 years back, when I was a principal in my college, I went to my Ayush department for some grant purpose. The grant they sanctioned me, that's different, but the amount budget sanctioned was 44 crores, sir. And in those days, modern medicine used to get 400 crores. This was a big difference in budget allocation to our community, I'll tell you. Things rapidly change, I'll tell you. Because our PM is definitely fond of our medicine, one thing. Secondly, he has a global look. He wants to globalize Ayurveda in such a fashion that tomorrow the world is going to see that this flourishes like any other pathy, I'll tell you. So, and similarly, what he quoted, that GR came from the central government, that Ayurvedic students or Ayurvedic degree holders, postgraduate can practice surgery, has all because of that PMO office, I'll tell you. And mind well, there is a big history. Shushu Samhita is one of the things that it's a written journey that the surgery existed in India. There is also a historical evidence that these books were carried from India to other parts of the country, translated, and then they came up. So जो कह रहे हमारे यहाँ पर कह रहे 3000 साल पहले हम बताते थे या जो पढ़ाते थे और उस समय वो प्राइम था, that was in the prime stage, I'll tell you. There are evidence where you had good hospitals in India where they used to were systemized, I'll tell you. For operation theatre there is a full detail how to make it, I'll tell you. Where which wood has to be used, what disha has to be there. See, all these things are all very scientific, only as Puranik said, this has to be now made it evident base and put it in the right manner so that the world recognizes very easily, I think. Now, I come to the surgical part in Ayurveda, I always feel it has been quite neglected. See, if you look at the history, I'll tell you, many students may not be knowing that the first kidney transplant in India was done by Ayurvedic surgeons, I'll tell you. It was in BHU. Dr. Deshpande, whose name came up for the Shar Sutra, he was one of the person. There were 4 more surgeons who were all from our Ayurvedic side. In those days where modern surgeons had not done any plant surgery earlier. First cornea transplant done in India was by Ayurvedic surgeon Dr. Sawant from Podar. He did it in JJ Hospital. This is all historical evidence. I was telling Dr. Puranik that these are to be documented to the world that how Ayurvedic surgeons have played a role in this country. The highest number of tubectomy done in India was the Ayurvedic surgeon from Maharashtra. If I don't mistake, from Nanded, who got the national prize for that. Now, as far as Podar is concerned, the history is I know very well because I have studied that. We had stalwarts, I'll tell you. Dr. U.C. Mehta, Dr. P.N. Awasthi, Dr. Nagaral, and they have served like, I'll tell you, you cannot believe in what condition they have worked and how they have brought it up, I'll tell you. I well remember in Podar only, I am telling you, that once there was a police strike actually. And there was a big riot, in Bombay. You won't believe, in one full day, I'll tell you, starting from 9 o'clock in the morning, next day 5 a.m. in the morning, we had almost operated 100 cases, I'll tell you. So, as far as Ayurvedic people doing surgery is concerned, I think there's no question, I'll tell you. The problem always comes up with the amount of training and the infrastructure. I have been fortunate that I was in Podar we had no doubt a better infrastructure, a good training, and that's why I could come as a surgeon up, I'll tell you. Definitely in Maharashtra there are a good number of institutions which have been imparting surgical training, but once upon a time, I'll tell you, there was a time when all these institutions, Nanded, Nagpur, Pune, Amravati, Nagar, these all institutions, were in the prime as far as surgery is concerned, I'll tell you. Modern medicine doctors also and Ayurvedic doctors used to come together and work out, Later on, as everyone knows, something goes wrong and everything becomes a problem. But still, I'll tell you, in Maharashtra, we are fortunate that we have a good lineup, we have a good affinity with the modern people also. They respect our science, they help us and teach us, I'll tell you. But the need today is actually need, I'll tell you, that we have almost 50-55 institutions in Maharashtra. But only 10%, I'll tell you, not to say, only 10% of the institutes have a good surgical workout going on, I'll tell you. Now it is time actually that all these institutes should develop this surgical faculty and show that we are doing good work. Because see, unless there is a good training and a good teaching, you cannot make a surgeon, I'll tell you. Because it requires extensive training, I'll tell you. And with the technology coming into this field, because I have been, observing the technology for a very quite long time, I'll tell you. And I am fortunate, I'll tell you, that I am working in a place in Sawantwadi where it's a very small area. Population is that 30,000-40,000 people, I'll tell you. But the amount of surgical work I do there with the help of my other surgeons is tremendous, I'll tell you. Why I am telling tremendous? We almost operate some more than 1200 cases per year. And this is not only anorectal, I'll tell you. This includes even laparoscopy surgery, urology, all types of general surgery, I'll tell you. Now this all is possible, I'll tell you. And when I see that, in cities like Bombay, Pune, why not other institutions come up? If in a small place like Sawantwadi, I can get the things moving in such a fashion. See, I have people, I'll tell you, coming for the surgery almost from 200 kilometers, I'll tell you. Karwar at one end, I'll tell you, I have people coming, Ratnagiri from this end, and sometimes even Bombay, they are coming there for surgery. Now, it's not boasting my thing, I'll tell you. It's nothing that I am boasting my thing, I'll tell you. Only thing I can say that my institute helped me to build up, I'll tell you. That is why I always say that the institute should help in building up the college, I'll tell you. And as I told you that right now, I'll tell you, there may be people who are opposing you, I'll tell you. But there are also people who are able to support you, I'll tell you. See, I remember, there were surgeons in my part who were opposing my surgical things. But there were surgeons coming from Goa, now still coming with me. They never opposed me, I'll tell you. There is a whole team of urologists coming from Keli, I'll tell you, which is a totally modern hospital. They come regularly for urological work. When I talk to them that what about their Ayurvedic college, I'll tell you, very surprising that there is no connection between the Ayurvedic Keli college and the modern Keli college. Now this is something disturbing, I'll tell you. I always feel that if you want to learn surgery, even medicine, there has to be an extensive clinical training, I'll tell you, which is now lacking again. We have seen in this COVID, I'll tell you, people lost touching the patient. लोगों ने हाथ लगाना बंद कर दिया और आज भी कह रहे पेशेंट को 5 फुट दूर रख के I am still not able to believe how you are going to examine the patient. See, the patient comes to you that you are going to examine him, I will tell you. और आपका उसके नाड़ी पे हाथ रखना या उसके पीछे हाथ रखना उसके लिए एक बहुत बड़ा सपोर्ट रहता है वो. सो इतना फ़र्क आ गया है कि हम लोगों ने पेशेंट को दूर रख दिया है. People are telling that telemedicine is going to change the, I think, still doubt, I will tell you. I still doubt, I will tell you. Because this medicine basically is a human approach, I'll tell you. It cannot become a technology oriented all the while, I'll tell you. Technology is going to help you, I don't say no. And technology advances, I'll tell you, one more thing I can tell you right now. The technologists are taking interest in your science now. See, everyone is trying to have a tie-up with the IITs now. Technology is definitely going to help, I'll tell you. But it cannot change the clinical medicine part, I'll tell you. So my humble request to all the students here is that you have to learn the clinical medicine if you want to be a successful practitioner. Whether you practice medicine, you practice surgery, you practice gynecology, anything, I'll tell you. And as far as Ayurveda is concerned, there is a big scope, I'll tell you. Why I am telling this is because, I have been visiting institutions all around India. There is something in the south, I'll tell you. सगळ्या विद्यार्थ्यांना मला एक रिक्वेस्ट आहे, आपण दक्षिणमध्ये कधीतरी जाऊन बघावा की तिथे खरे लोक करे आयुर्वेदिक प्रॅक्टिस काय करतात. हे शुद्ध आणि अशुद्ध ह्या गोष्टींमधनं बाहेर पडा. देयर इज नथिंग लाईक शुद्ध अँड अशुद्ध, आय टेल यू. एव्हरीथिंग इज शुद्ध. समटाइम्स पीपल हू प्रैक्टिस बोथ द प्रैक्टिस दे सेड ये तो इंटीग्रेटेड है, मिक्स प्रैक्टिस है. सी, इट इज नथिंग रॉन्ग, आई टेल यू. Mixed practice is for what actually? It is the welfare of the patient. And you are not doing anything wrong, I tell you. So I am coming back to that point that South, what it has got. Sir, I will tell you, there, especially that Marma Chikisa, Asti Sandhi Rog Chikisa is wonderful, I will tell you. You cannot believe, I have a friend who has got a 200-bedded hospital, sir. So you can imagine orthopedic things going on in a 200-bedded hospital, and it's a private hospital, it's not a government hospital also. Similarly, Visha Chikitsa, which I had never heard actually. The first time I saw was in Kotakal. And it's really wonderful. Patients, more than 200, I'll tell you, daily OPD. Manas Rog Chikitsa. Again I'll tell you, they have got a Manas Rog Chikitsa. Snake bite, this Visha Chikitsa they are also doing it. So I think it is time now that we understand our science has got a big potential, I tell you. And our students should learn almost all these branches, not one branch only. Learn all the branches, you select a specific thing which is going, where you are going to use all these branches for that purpose. When I started my practice in Sawantwadi, I know it was a very difficult time because to establish as an Ayurvedic surgeon or a Ayurvedic person doing surgery, it's a very difficult job. The first question comes whether you are entitled to practice or not, which probably the PM has solved it out. Second thing, what is the amount of training you have received? Anesthetists refused to come to the hospital. I was fortunate enough to learn anesthesia from my sir, and I continued and I still continue, I'll tell you. Some of my colleagues tell me, that doctor, आप कुछ हो जाएगा तो क्या करोगे? I tell them, it is all for the welfare of the person and I am not doing anything wrong, I'll tell you. So what I mean to say that struggle is going to be there whenever you come out. So it's very important that the institutes have to now develop all these things so that that product when it is outside, it is more useful, I tell you. And that is what everyone wants actually. Because if you look at the CCM, the first line the CCM says, to produce a graduate of Indian system of medicine who has concurrent knowledge of modern medical sciences and who will be useful to the society. So I think the goal is very clear. There is nothing that you can't learn modern things, you can't do anything. Everything is possible, I'll tell you. And I know I have many people here, Dr. Sangvi is here. He has been struggling throughout, and recently he has been called to Egypt to deliberate something. Now see, this is something very good, I'll tell you. That outsiders want to learn Ayurveda, they want to have interaction with you, and I think the field is open now. And Dr. Dwivedi, I'll tell you, you should praise him, whatever say, with his little efforts and the institutional support, maybe 10 years, I think 10 years is not a big thing. Any invention you require a lot of money. But the main important that you go on about it. आप उसके पीछे लगे रहे, उसमें जो भी कमियां थी उसको आपने दूर करने की कोशिश की. वो जो एक कह रहे क्राइटेरिया रहता है कि किस तरह से उसको पेटेंट हम सी अटेंडिंग ए question answer session for 2.5 hours is not a simple thing, I tell you. So once again I congratulate Dr. Dwivedi for his innovation and wish him more success. And also he should come out with some more things. But definitely I have a word for caution with these anorectal things, I will tell you. See, the things are changing, I will tell you. The anorectal surgeon has to change a lot, I will tell you. Why I am telling that, that as we have changed the dress, similarly you have to change yourself now. You have to learn the modern things, which is very important to you. You have to know what is the right thing to be done and what right time actually. See, I well remember, I attend these modern conferences frequently, I will tell you. And to my luck, I will tell you, I have attended medicine conference, surgical conference, oncology, gynecology. See, I have not left anything, anesthesia. Why I do it? Because I learn something from this, I will tell you. Keep your eyes open, I will tell you. All these branches are going to help you. And as I told you, someone was telling me that sir is doing hysterectomy. See, this also I started doing it because there was a need at that time in my hospital. 2 gynec surgeons had left the hospital and the flow was there. So what to do? And we have actually always trying to be catering services to the persons who cannot get treatment other से. यानी मेरा एक गोल रहा है कि जिन लोगों को कह रहे मेडिकल फैसिलिटी हम दे नहीं पा रहे हैं या जो कहीं जा नहीं सकते हैं उनको हम यहाँ पर किस तरह से दें. And that started my journey to that gynec side, I will tell you. You won't believe, the first time I did a cesarean, I will tell you, I finished in 20 minutes, sir. 20 minutes. I did 14 surgeries in 1 month, I will tell you. But then one episode happened, lot of problem came up and so I left the thing. But then other side, hysterectomy, I still continued. And I will tell you, to my luck, whatever you can say, and support of my well-wishers, almost I have operated more than 1,000 surgeries, I will tell you. So this I am just telling you that, the field is very open. One more I can tell you, I will tell you. The branch of onco. Every time we feel that this oncology, ये हमारे हाथ का नहीं है, हम कुछ कर भी नहीं सकते हैं. I happened to start this onco breast surgery. One lady came from Ratnagiri. I hope you are permitting time. Okay. See, this is just to boost my students, that, this lady came from Ratnagiri and she had a breast cancer. I told her, why don't you go to Bombay? She told, I am not able to go because I don't have anyone to support there. This is the first case I did, I will tell you, in Sawantwadi. Till then, I used to take the patient to my friend oncologist, go there, see them working, and I used to come back and help the patient. But this was the first time that I thought that this patient, why she should be deprived of the surgery because she is not able to go to Bombay. The economy was not supporting her, her supportive system was little weak. So this I started my journey with the onco surgery of breast, I will tell you. Every year, sir, to my good things, almost I am operating now 15 to 20 cases. And within the span of 20 years, I am almost operated 500 years. And I feel very upright, that they are all living, I will tell you. And next I will tell you one more part. This breast surgery, they require chemotherapies. Initially I used to send them, but the problem came up. I heard one story from Bombay, I will tell you. One patient came from our place, she got operated in Thana and chemo and she had to send a house, I will tell you. आपलं घर तिने विकून टाकलं, कारण काय इकडचं काय खर्च त्याला परवडत नव्हता. आणि हे बघून मला असं वाटलं की ह्यालासुद्धा आपण आपल्याकडे व्यवस्था करूया. आणि असं करून ज्यावेळेला मी माझ्या ऑन्को सर्जन मित्राबरोबर बोललो की सर असं मला, तो म्हणाला तुला काय पाहिजे म्हणाला. नाही म्हणाला मला तुम्ही एक सोर्स द्या की जो मला स्वस्तात औषध देईल. त्यांनी मला डायरेक्टली कंपनीशी सांगड घालून दिली. आणि आपल्याला सांगू इच्छितो की त्या एका गोष्टीमुळे आज मी माझ्या इन्स्टिट्यूटमध्ये ही केमोथेरपी पूर्णपणे दिलं देतो. काही लोकांनी मला प्रश्न विचारला की सर तुम्हाला अधिकार आहे का, तर मी म्हटलं हा अधिकार ठरवणारं कोण आहे. पेशंटचा जिथे भला होतो आहे तो अधिकार मी जर नाही गाजू शकत तर दुसऱ्याला मी विचारून काय करणार आहे. आणि याचा मला फायदा झाला ह्या कोरोनाच्या दरम्यान. आपल्याला सांगतो कोरोनाच्या दरम्यान झाला कसा होता की सगळीकडे ट्रान्सपोर्ट बंद होता, माणसाचं येणं जाणं मुश्किल होता. आणि जिथे ते लोक केमोसाठी जात होते, जसं गोव्याला जात होते, मुंबईला जात होते, कोल्हापूरला जात होते, त्या लोकांना सगळीकडनं नो म्हणून ॲन्सर यायचा की हे कोविड संपल्यानंतर या म्हणून. आणि केमो आपल्याला माहिती आहे की त्याला 8 दिवसांनी, 15 दिवसांनी, 21 दिवसांनी असं त्याचा एक तो प्रोटोकॉल असतो. तुम्हाला माहिती म्हणून सांगतो सर, ही सगळी मंडळी होती ती आपल्या इन्स्टिट्यूटला आलेली. आणि एक दिवस जात नव्हता की आम्ही केमो देत नव्हतो. तुम्हाला सांगतो एका वर्षामध्ये 300पेक्षा जास्त केमो दिले सर. आता मी कसं बघतो की हे एक चॅनल आम्ही त्याला करून दिल्यानंतर ते सोपं झालं. सिस्टर आज माझ्याकडे, मी इथे जरी उभा आहे तरी सिस्टर तिकडे केमो देते आज. तर मी काय म्हणतो की हा जो एक प्रकार असतो ते मी सगळ्यांना सांगू इच्छितो की आपण सगळ्याकडे ही पॉवर आहे. आपण ह्याच्यात अडकलो की नाही, हे मला करता येणार का नाही, ते करता येणार, काहीच करता येणार नाही तुम्हाला सांगतो. कारण तुम्हाला जो राह दाखवणारा असतो ना तो तर तुम्हाला म्हणतो सगळंच करा, पण असे दाखवणारे खूप असतात की हे तू करू नको. सो मला असं वाटतं की नाहीपासून जर आपण सुरुवात केला आणि करायला लागलो तर तुम्ही सगळंच करू शकता. आणि मग शुश्रुताचं तो वाक्य आठवतो की तुमचा हात जो आहे तो प्रधान यंत्र आहे. हस्तन प्रधान यंत्रम जो शुश्रुत सांगतो तर यू ट्रेंड युअर हँड्स आय टेल यू, आणि सी दॅट युअर हँड्स आर सो गुड दॅट इवन इफ यू पुट ए पॅट ऑन द पेशंट्स शोल्डर द पेशंट इज हॅपी आय टेल यू. सी आश्चर्याची गोष्ट मला जेव्हा होते सर की मी ज्या वेळेला ओपीडीला काम करत असतो आणि एखादा माणूस येऊन पाय पडतो सर, मी ह्याच्यापेक्षा धन्य मला कधी समजत नाही. मी म्हणतो की ह्या माणसाचं माझं काही घेणं देणं नाही आहे. तो केवळ मी त्याला काहीतरी बरा केलेला आहे म्हणून तो आज तर एवढा तुम्हाला सांगतो सन्मान कुठेही मिळणार नाही. तर आपला एक फील्ड एक असा आहे जिथे सामान्य माणूस तुम्हाला सन्मानपूर्वक वागणी देतो आणि एखादा करोडपती असला तरी तो खाली झुकतो. सांगायचं मला काय आहे, एथिक्सला आपण पाळलं पाहिजे, जे आज हळूहळू लुप्त व्हायला लागला. पण मी म्हणतो ना की जगामध्ये एथिकल काम करणारे लोक खूप आहेत आणि त्याच्यामुळे हा शास्त्रकार्य प्रगत करतो आहे. आणि आयुर्वेदाकडे जर बघितला तर आयुर्वेदाचं सगळं शास्त्र हे एथिकलच आहे. सर आपल्याला अजून एक गोष्ट सांगतो. एकदा आहे ना मी आत्ता ऑल इंडिया इन्स्टिट्यूट ऑफ आयुर्वेदला व्हिजिटिंग कन्सल्टंट म्हणून जातो, तर तिथे एक मीडियाचा एक पर्सन आला, तुम्हाला एक डॉक्टर तुमच्याशी चर्चा करायची आहे. तर मी म्हटलं काय, व्हॉट इज युअर सब्जेक्ट. तर म्हणाले की आयुर्वेदिक प्रॅक्टिशनर सर्जरी करू शकतात की नाही ह्याला मला चर्चा करायची आहे. तर मला माहीत होतं प्रॉब्लेम्स येणार ते काय, क्वेश्चन तेच असतात की एंटायटल आहे की नाही. आणि माझ्याबरोबर IMOचा प्रेसिडेंट होता. आता ही व्हर्च्युअल मीटिंग झाली ज्याच्यामध्ये हे मीडियाचा पर्सन मला विचारत होता की असं आहे तसं आहे आणि एथिक्सबद्दल बोलायला लागला तो. तेव्हा मला मग जरा थोडा खटकला. मी म्हटलं मॅडम होती ती, मी म्हटलं सी यू डोंट हॅव टू टीच एथिक्स टू आयुर्वेदिक पीपल आय टेल यू, बिकॉज आयुर्वेदिक सायन्स हॅज बीन ब्रॉट टू द ह्युमॅनिटी फॉर ऑल एथिकल पर्पज अँड ऑल एथिकल कॉजेस म्हटलं. अँड युअर एथिक्स वी हॅव सीन इन कोविड पिरियड. कोविडच्या दरम्यान एथिक्स लोकांनी काय पाळलं हे जगाने बघितलं आहे. ती मीडिया पर्सन गप्प झाली. आणि IMAचा प्रेसिडेंट जो होता, जो करे त्याला वाटत होतं आपण काहीतरी खूप बोलणार. मी त्याला एकच शब्द बोलला, म्हटलं इथे करे हजारो वर्ष म्हटलं हे सर्जरी प्रॅक्टिस केली गेली आहे. आणि मी म्हटलं आज इथे करे 40 वर्ष काम केल्यानंतर आज तुम्ही मला म्हणणार की तुम्हाला अधिकार नाही आहे. मी म्हणतो कोणी दिलं तुम्हाला अधिकार म्हटलं बोलायला हे. मग तो ज्यावेळेला करे त्या IMA प्रेसिडेंटचा करे वेळ आली तर तो एवढाच म्हणाला की आमचा करे विरोध नाही, आमचा विरोध आहे की ह्या लोकांनी फक्त करे MS लिहू नये. मी म्हटलं चला एवढा तरी खाली आला तो. तर समजून घ्या, मला सांगायचं काय की जे करे चांगले लोक असतात त्यांना विरोध काही ठराविक गोष्टींशी असतो. तुमच्या पॅथीशी फारसा विरोध नसतो तुम्हाला सांगतो. आणि जगामध्ये कुठलीही पॅथी वाईट नाही आहे. आपण कुठल्या प्रकारे प्रॅक्टिस करतो ह्याला खूप महत्त्व आहे. आणि जाता आता मी आपल्याला सांगेन की सर्वे संतु निरामय सर्व सुखानि भवन्तु मा कचित. हा जो आपला करे एक ब्रीद वाक्य आहे हे सगळ्यांनी पाळावा. हा पथ्य पाळल्यानंतर मला असं वाटत नाही की कधीही आयुर्वेदाला वाईट दिवस येणार आहे. धन्यवाद.
Thank you so much, sir, for broadening our mind with your precious words and valuable guidance. Now, I would request respected Ranjit Puranik sir to felicitate President of the function, Dr. Rajeshkumar Gupta sir. Request Vaidya Sanjay Satpute sir, Principal of Sion Ayurved Mahavidyalay, to give vote of thanks. Please, sir.
Good afternoon, one and all. It's our privilege proposing vote of thanks in Mala organized by Ayurvidya Prasarak Mandal and Mumbai Vaidya Sabha in memorial of late Vaidya Shankar Dajeeshastri Pade. Today we witness the third excellence of two Dhanvantaris, Shalya. We cherish the presence of Rajeshkumar Gupta sir as president in today's lecture. Vidya Dadati Vinayam. He is a man with great learning attitude. He is skilled, competent, yet mannered. We thank you very much, sir, for your valuable thoughts. I would like to thank our today's eminent guest speaker, Dr. Amarprakash Dwivedi sir. Sir, you mesmerize with your potential thoughts. धारिभ्यो कर्मिणो श्रेष्ठः असं म्हणतात. ज्ञानी समजणाऱ्यांपेक्षा कृतीत असणारे वैद्य श्रेष्ठ असतात. इंटेलेक्च्युअल प्रॉपर्टी ऑफ इंडियाकडून पेटेंट, क्षारसूत्र, करिअर कम ॲप्लिकेशन डिझाईन्स. दिस इज द ग्रेट अचीवमेंट. ही इज द फर्स्ट in India who received the patent for any medical device. Sir, your lecture was very informative, interesting, comprehensive. Thank you very much, sir. I am thankful to Vaidya Rajendra Sharma sir, Secretary Mumbai Vaidya Sabha, for giving his valuable time. I express my sincere thanks to Puranik sir, Adhyaksha Ayurvidya Prasarak Mandal, a man with great wisdom and perception. His clarity, commitment, I can take it attitude and confidence enabled our institution to reach high heights. इनका दीदार एक त्यौहार से बड़े कम नहीं होता. A big thank you to all trustees. I can name the few. Sadiq Ahmad sir, Marwankar sir, HB Singh sir, Solanki sir, Patankar sir, Sangvi sir, all dignitaries, worthy teachers, and our beloved students, Dr. Keni sir and all his team who work hard to make the event happen successfully. Thank you one and all present here. Thank you very much.
Program, I would request everyone to stand up for the national anthem.
Jana Gana Mana Adhinayak Jaya He Bharat Bhagya Vidhana जलधितरंग तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे भारत माता की